that's really important. So we can use both MRI and CT we've talked about, right? MRI is where you're going to see the GTV. CTs, though, are just as good, but you've got to remember that the CT will over contour compared to the MRI. So you've got to be really careful. And what I usually do is I look at the MRI that I do before the CT, measure the size of the cervix, and that's what I use. Because if I just contoured on the CT, my cervix would be 5 or 6 cms. If I use the MRI and I measure that it's 3 to 4, then that's how the width of my cervix is going to be. The CT does over contour. It really over contours more by the width. So it's really important to know exactly the size of your cervix. The CT will shows changes in the perimeter of the uterus, but not as reliable as the MRI, but it does help you with the normal tissues. So again, the pros to CT guided GYN is widely available. It is less expensive. It's more efficient to use. It's easier to plan. It's easier to do catheters and applicators dislocations. The cons are it does not show you the GTV, and it does show you it is inferior to the soft tissue resolution and vaginal involvement. So practical, this is why I'm here, right? So what are some practical tips and things? Key is pre-review of breaking. So how do you do the workload? One, you gotta decide what you're gonna do at the time of breaking. Here at MD Anderson, we always do an MRI, right? Pre-breaking, and then we decide what we're gonna do next. I know that's hard for you guys, but even doing a CT will show you if the tumor has reduced in size, what it looks like before you even do the breaking, and that's important. You also need to look at the patient. You need to do an anesthesia evaluation, anticoagulation. You need to look at the CBC, look at ANCs, platelets, hemoglobin, right? He is ANC. I know there's a debate. Ours is ANC less than 1. We do give shots to stimulate the neutrophils, right? So we do give Neupogen. Platelets, usually anything below 20, we will not do brachy. But anything above 20, we will do brachy. So platelets are really important. And you do need to look at that. 20 really is our breakdown. If it's below 20, we may do it, but then we're giving platelet infusions during the brachy. Above 20, we will just proceed on and giving the brachytherapy. Anesthesia, again, for us is very easy. We do generally anesthesia for all patients. I know that's harder in low and middle income countries. So fentanyl and Ativan are great Smith sleeves if you can get them. Again, very expensive, but are very helpful if you are going to use a fentanyl or an Ativan. Also, if you don't do general anesthesia, using that rectal retractor is much easier than packing, and it does help move the rectum away. Because we do general anesthesia, use packing both anteriorly and posteriorly, but if you don't, a rectal retractor is great, and then you just pack anteriorly. Ultrasound guidance, I know you guys have already had a talk about that. We do ultrasound guidance to guide our tandem every time. It's really important. I know you guys got to talk about how to use ultrasound guidance for planning. We don't use that for planning, but we definitely do ultrasound guidance to guide our tandem. So in the OR, we use our ultrasound guidance to sound the patient. We set the flange about a cm shorter than what it sounds, because as you put the legs down, the tandem will go in, right? So more. So it's important not to, so if you sound the uterus to 7, set the flange at 6, or find the tandem that's at 6. Because as you put the legs down, the tandem will go in further and you don't want to perforate. And that's really important. And then in the packing, which is important, you do anterior and posteriorly, or you use a rectal retractor posteriorly and you pack anteriorly. There's lots of now key. All of these, I mean, this is actually not all of them, right? But now we are really using CT and MRI compatible applicators. Very important to use. Multiple different types. There's the standard ones that don't have the needles. They're the ones that have the needles. So you can see here's a tandem and ring with needles. There's the Venetia, which is our favorite. We also use, because we use elective, we also have a lot of cool ovoids with needles, but there's just so many different instruments that you can use different types depend on every fraction, depending on what you decide. And that's what we do. Like I just did a case where we did 2 fractions and we just did the Venetia with the caps, right? And with some needles. And the next 3 fractions, we're gonna go back and we'll not use the caps and we'll use oblique needles to make sure that we can get. So key, you don't, just because you use one and the first fraction does not mean you have to use the same one the next fraction. What you do is you look at the imaging, you look at your plan, and you decide what is gonna be the best applicator to use the next time. And then you can go back to the same one too. So what is the difference between tandem and ovoids and tandem and rings? And everybody asks me that. And I do know, again, in most of Africa, tandem and rings is used most often because it is the easiest to use when you don't use general anesthesia. So because we use general anesthesia, we tend to use a tandem and ovoids. But there's slight difference between the tandem and the ovoids and tandem and ring. Tandem and ovoids does give you a lower bladder and rectal dose, and it gives you the tandem and ring gives you a lower bladder and rectal dose, but it does give you a higher vaginal dose. And that's what you gotta remember. So with needles, again, you do get a higher dose with the tandem and ring, and it doesn't give you as much lateral throw off. So why we use tandem and ovoids, we do get a lot better lateral throw off, and our bladder and rectal doses are decent. So I think the key, and our vaginal doses are lower. The key to remember is that with the tandem and ring, if you load that ring really hot, your vaginal surface is going to get really hot, leading to vaginal stenosis. That is the issue with that, because the mucosa is so close to the ring, it does give a higher vaginal dose. So key is you got to pack, and the packing is the most important. Besides it stabilizing the implant, it does reduce the dose to the bladder and rectum, and depending on how you pack. You don't want to pack above and push the cervix away. You don't want, and so key is to make sure that you pack correctly, and this just shows you how to pack. You don't want to pack where you're pushing the cervix away. You want to push the bladder and the rectum away. Yes, the rectal retractor will help, but by pushing the rectum away, and you can just pack anteriorly if you want, but more importantly, remember, don't push that cervix away. And this just showed you our workflow. We always do an MRI before we plan. Before we do the implant, and we do pre-plan, especially if we're gonna do needles, we do pre-plan. And then at the time of the brachy, we do the procedure, we'll do a CT scan, we then do our planning, contouring, and then we treat. So what are some complications? So let's look at this ultrasound. This ultrasound, you can see the uterus, and there's a tandem that goes straight in, right? So what do you see here? You see this tandem, right? See this tandem? What is it? It's surrounded by valve, right? Do you see that? So this is a patient with a perforated uterus, right? So the tandem.
Yeah, okay. Quickly tell us.
Anija, if you can hear me with you, can you hear me?
You lost.
Oh, okay. We lost audio for a second, just when you change your slides. I'll let you know once the audio is back. We're still waiting for it to come on. So just hold on 1 second. I don't know.
No, it's just.
Where's the technical team? Is it from here, or is the technical team a connection to the speakers?
Why are they not on their seats?
It's from here?
It's from here.
It's from here.
Because online
They can hear her.
still here. Why are these people not on this?
Please, can we have the technical people just always be here? We don't need to be calling for, it's just coming in. Eh? Somebody needs to be here. And that's the second time it's happening in this meeting.
You can put that there. I just sit down there. All true. That's why you're here.
Okay, Anita, can you speak? Let's see if we can hear you.
Yeah, can you hear me now?
Absolutely fine. Thank you very much. Sorry about that. We fixed it. You can go on.
It's all good. It's all good. It's all good. Okay, so we're gonna go back. Sorry about that. We're gonna go back. Okay, so how does this happen? So you have a retroverted uterus. So you see this uterus, and you see the you see where the you can see where the whatever the canal is. Sorry. Right, so in this case, you want to actually, when you sound that patient, you want to turn the sound and go backwards, right? But a lot of people will not do that. But the other thing is, especially with the tandem ring, as you're rotating, you may actually perforate, right? But a key, easy place for you to perforate a patient is with the retroverted uterus. So this just shows you, so you can see, right? Here it is, right? This is actually a tandem ring, right? So it was a retroverted uterus, and they actually tried to rotate the uterus, and it went right through, and you can see where the tandem is going right through. So what do you do in these cases? What you do is you want to, if you're doing a CT live, right? You want to pull the uterus, you want to pull the tandem out, and then reposition, you can treat, right? But if you're not doing live, please don't. And the other thing you could do, I mean, this is the worst case scenario where really this is just not even in the canal. But if it's mostly in the canal and it's only perforated a little bit, just don't load the tandem that's outside the uterus. So you don't load those dwells. I would definitely try to reposition because we do live CTs. But if you're not doing live CTs and it's mostly in the canal, treat what's in the canal, just don't load the dwells that are outside the uterus. And then the next time fix it, right? But perforations happen about 9% of time, and they usually don't cause, I mean, the rate of perforation is about 14%, right? But about 9% of them, you did not realize it until you do the imaging. So it's really important to know when you perforate and not load the tandem that's outside the uterus. And this just shows you, see, this is where, again, it is a tandem ring. Tandem rings are probably the ones, but it is a retroverted uterus, right? And you just went right through. Key is to sound and put the tandem this way and then rotate. Now, if you can't, and that's a big question people ask me, most of the time you can rotate the uterus. And you want to rotate the uterus, right? Because otherwise you're going to radiate all of the sacrum and it could cause higher doses to the sacral nerves that can cause some issues, right? Now, if you can't, and sometimes you can, and there's been times, there's 1 or 2 times, it's rare, but if you can't, then just go ahead and radiate with it turned like this, but make sure you're looking at your sacral nerve doses. But I would say 95 to 98% you can rotate the uterus correctly and treat. But there are going to be definitely some times when you cannot, and then you do, but make sure you look at your sacral nerve doses when you do that. What are the perioperative complications? Bleeding, silver nitrate or Monzos, impacting will help. Laceration, if you do have a laceration, then you need to take everything out, and usually sometimes just pressure will stop it, but sometimes you may have to. So that area of laceration and perforation that we talked about, if it's a true perforation, you may need antibiotics, but the rule right now is as long as you don't treat and you immediately take care of the perforation, you do not need antibiotics anymore. Okay, key, this is important, especially if you do interstitials, is a stitch. Now, a stitch is important to keep traction on the cervix. So even if you use tandem and ovoids and tandem and ring, and if the cervix is mobile, throwing a stitch and holding that stitch while you pack and all of that helps. But stitch is more important when you do needles. The reason why the stitch is more important is this, is you're trying to push those needles in, you can push the entire cervix away and the instruments away. So we actually will put stitches in on both sides of the cervix and hold the stitch as we're pushing those needles in. So it's become even more relevant, that stitch, especially with interstitials. And you do not want to use a pop-out needle because you want to be able to take that needle and then cut it because you don't want it to pop off inside the body. And this is just an example of a patient where they used a pop-off and look, it got left. So you want to use one that you cut off, you don't want to use a pop-off. But especially with needles, that stitch is going to be important because you got to keep traction on the cervix. For narrow vagina, key is you just got to be careful and make sure that you pick the right instruments. So I know I'm a little bit running out of time, so we'll just talk about a couple of things. Exophytic tumors are challenging because of bleeding. Again, silver nitrate or Monzel, really important. Key is you use the applicator that's best fit for the situation. Like I say, I could use 5 different applicators for my 5 different HDRs, and sometimes I do. And that's, you just have to do that sometimes. Why is a CT important every fraction? So let's say you're doing two fractions at a time, right? So you do 1 fraction in the evening, and then you do 1 fraction in the morning. You've got to repeat a CT for the fraction you do in the morning. And this just shows you, this is a patient, we did 1 fraction in the evening. You can see this, and you can see because the patient had a big fibroid, the tandem was posterior. This was the initial afternoon fraction. So the next morning, we did a CT. This is the CT the evening before, actually it was morning of, that evening. This is the second fraction. Look, because the fibroid moved, the tandem moved, the entire system moved. Yes, we treated it, but now we have to replan because you can see where it moved just from the morning to the afternoon. So if you are doing 2 or 3 fractions using the same system, repeat a CT and reevaluate, and if you need to, replan. But it is really important to do a CT and verify it before you do the second fraction. That's key. Look at, just huge difference, right? And this just shows you the coronal view, right? What happened? See, this is the morning, the afternoon. The fibroid just moved, but it's not just the fibroid. It could just move gas bubble. Anything could change the geometry. Just another example of tips and tricks, right? Here's 1 fraction, and you can see where the bowel is really falling right into my fields and the sigmoids right there. So how did I fix this? So my second fraction, what I did was I filled the bladder and it pushed the bowel away. Most people actually will do about 100 cc's in the bladder no matter what, and then image and decide if they want to keep it that way or not. We usually do an empty bladder and then decide if we need to fill it. But key, as you can see, here the bladder is totally in my field, right? By changing just the bladder filling, you can see I push the bowel right out of my field. So yes, it will increase my dose to my bladder, but the bowel gets less dose. Again, and you can change this. So the first fraction we did empty, where the bladder got less dose, bowel got a higher dose. Second fraction, we filled the bladder, bowel got less dose, bladder got no. So you can just mix and match. And sometimes we'll do that where 2 fractions we do full bladder, 3 fractions we do empty. Is getting a higher dose. So just quickly, this is the patient who presented with a 6 cm cervical mass, extension into the upper third of the vagina, bilateral parametrial involvement, squamous cell carcinoma. This shows you this huge tumor, right? Really big tumor. So this is my MRI at 4 weeks. Amazing in response, but she still has this disease that's going down the parametrium. You see that, right? So what we did was we first treated it with just straightforward tandem and ovoids. But you can see where we're missing some disease. So the second time, we added needles. We did the venesia with needles, and we also just treated that parametrial disease. And so we got a better, so a lot of times what we'll do is we'll do the first implant straightforward. And a lot of people don't. A lot of people will do the first implant and go ahead and put the needles and decide what needles to use. We tend to do the first implant straightforward, whether it's Venezia or tandem ovoids, and then decide if we need to use the needles, and then pre-plan for the needles for the next implants. And this just shows you the implant with the needles, gorgeous, right? When you're treating everything that we want. And just going through this different slices, you can see how well it really is treating that disease that came down. Another case, huge tumor right here, or we decent, right? You would think a tandem and ovoid would actually be able to treat this. And so we did a tandem and ovoid, but we were still really missing disease on the side right here. And look at this, the sigmoid just wraps around, right? Really wraps around the uterus. So by adding needles, so we decided that we were gonna add needles, right? See that? And we were able to increase the coverage to the HRCTV while reducing the dose to the sigmoid and bladder. Post-op complications that you do need to worry about, DVT, bleeding, and as you remove the implant, especially if you're using needles, make sure you take the needles out first, right? And then take the implant out. Because if you take everything out, again, you could have lacerations. So you have to be very careful when you're also removing the implants. So this, I think, is probably the key to my whole talk. You gotta balance the risks and benefits on deciding how to treat a patient, right? So if you've had a complete response and the tumor's about 4 cms, intercavitary probably is enough, right? If you've had a partial response, then you probably need to add some needles. If you really have a poor response, key is you have to add needles. So I think, again, this also tells you the doses that you need, right? Complete response, minimum dose to the HRCTV should be about 85. Partial response, minimum dose should be 85 to 90, right? If you have poor response, you really should go higher than 90. So this is probably the most important slide on my talk. And I will send you the slides. But key embrace has shown that about 30% of cases do need interstitial brachy. You do need it probably for tumors that are bigger than 4 cms. And like I mentioned, this is probably the most important slide on my talk. And I hope that helps somewhat. And if I can answer questions, I'm happy to answer it. Thank you for allowing me to talk. And I appreciate everything. Thank you.
Thank you, Dr. Adija. I hope you could hear the resounding applause. While you were speaking, I could see people jotting furiously because it was relatable, it was very helpful, it was something that would actually help to move the practice forward better. I noticed this. I kept looking around the room because I don't do brachytherapy myself. I'm still a fantastic doctor, nonetheless. However, a lot of people who do that were just properly engrossed. So we thank you very much for the practicality of it, the relatability, and of course the wealth of knowledge that you showed. I must add though that at some point I just really felt downcast. Did you say 5 HDR machines in your center? 5? You said you use 5. 5.
We do 5 fractions. But you can add. I forgot. I had a slide with doses. You can do 4 fractions, or you could do 3 fractions, right? It just depends. Like this one patient I had yesterday that I did, right? We're doing 5 fractions because we were going to do 4, but we weren't getting enough dose. So I think you have to look to see how you're doing it. What dose you're getting, and then you decide what fraction to use. I didn't talk about that. You can definitely use 3 fractions, and we talked about that. If you get great dose. 4 is the standard fractionation. We mostly do 5, but if we get good dose, we'll do 4.
Okay, thank you very much. We have some questions, so we'll just take them now. Dr. Falasher.
Thank you very much for the presentation. My from your experience, I don't have that experience, and that's why I'm asking. You talked about rotating or manipulating the uterus. In your experience, how practical? How do we do that? How do we achieve it? Is it that we use our hands to rotate
Yeah,
it?
we do it all the time. Again, this last patient that yesterday's patient, I just to tell you, it's retroverted, it stayed retroverted throughout my treatment. We were able to rotate it and it stays rotated. Once you put the ovoids, it will stay rotated. It is important, I'm gonna tell you, if you can rotate the uterus back to normal position, it really does help your dosimetry. You don't blast the sigmoid and you don't blast the sacral nerves. I've had 2 patients where we probably gave, because it was too high in the pelvis, we probably gave too high of a dose of the sacral nerves, and both of them had difficulty walking for a while. So that dose of those sacral nerves is important. Like I say, I think 95 to 98% you can rotate. Now, if you can't. And it's better to go ahead and treat not rotate it. The majority of the time you can rotate it and you should rotate it.
So Anuja, the question though is, if you would be kind enough,
Yeah.
is how do you rotate? How?
Oh, right, okay. So you put the tandem in, right? And then you rotate. So you do go in backwards and then you rotate with the tandem. And then you fix it with the ovoids. And we watch it with ultrasound, so we'll put it in and we watch it rotate with ultrasound, and then you fix the ovoids and it stays straight. I promise you.
So we do need to have the ultrasound scan. We take your word for it because we know you're a guru at what you do. We'll be taking your word for it.
I just did it yesterday. I promise it works.
Well, so maybe at some point in time we'll also have some more hands-on training there. It seems a little bit focus. Right now, just picturing it. But I guess we just need more experience within that, then we'll be able to figure out how that gets done. Again, I mean, mastery and wizardry are on the same level with you, so we really appreciate that. Are there any more questions? Maybe practical questions about what you do. Okay, I have. Would you mind coming forward, sir, please, because of the mic, so that we can hear you. My right.
Oh, my right. Thank you for your presentation. I wanted to ask, you made mention of patients who would have to sleep over and experience with a shift. So you said you correct it by filling the bladder. What if that doesn't work? How else can you correct that shift? That's my question.
So you have patients that are staying overnight and you do a CT scan. You just have to replan it if there's a shift.
Okay. You replan.
You just replan it. Just replan it. I mean, as long as the system is still decent, I would just replan it and then do, the next time do it differently. But that's where the packing is so important, right? And I have to say, and I hate to tell you this, and we do this, unfortunately, if we're keeping somebody overnight, like this patient I had last night, so we treated her last night and we're gonna treat her this morning. We do put sutures in the 2 labias and we tie it, right? And that helps it from not shifting as much either, right? So we put 2 sutures on both labias and then we tie it. Not real tight, but we tie it. So then that also helps stabilize the whole system, especially if you're keeping somebody overnight. Does that make sense?
Yeah, it does.
I probably did need to take a picture of that. And I should have done, because that's exactly, for all patients that we keep overnight, we do suture the labia together, and that also helps keep the system in place without shifting so much.
Good. Okay. Thank you, Anuja. We can relate to some of the things that you're saying, and that's practical and probably helpful. I don't know how many times a patient taking brachytherapy will have access to gym in this part, but I guess maybe people will tell us how often they re-image their patients and all of that. Do we do CTs as frequently as Anuja is implying, Dr. Adekwe?
No, so we do for every function, for the time and
For every function.
Patients have not been sleeping over, and then you are doing interstitial, you want your patient to sleep over, you don't want to repeat the whole of that, so you need to be doing that. That's actually the idea.
Okay.
Because if under 4 hours that shifted, how much more overnight? I am moving the patient to the
ward and back again.
And all these or what dates are not even possible. So definitely.
Okay. All right. Thank you. Do we have any more questions? Okay. Well, thank you, Dr. Anuja. As always, dynamite presentation, dynamite personality.
We will see you at tumor board. I'll be there at tumor board. Have a great day, you guys.
All right then. Thank you so much. Dr. Adekwe, do we move on?
Yeah.
Okay, great. All right. So let me just get.
No, it's not.
Use the one.
Oh, okay, great. Sweet. All right, so first of all, Dr. Joy Ogumuyiwa, that's our next speaker. First of all, our apologies for the delay. Thank you so much for being so gracious and waiting on us. We are so happy you. Dr. Joy Ogumuyiwa is going to have a conversation with us on local clinical trials and outcomes research in brachytherapy. Dr. Joy Ogumuyiwa is a Global Oncology Fellow at Memorial Sloan Kettering MSK Cancer Center in collaboration with the African Research Group for Oncology. She focuses on improving limited settings and on the design and evaluation of evidence-based health interventions. She also has a master's in public health at prestigious Harvard University, where her research addressed social and behavioral determinants of health and strategies for advancing equity in global health systems. For the lightning talks on local clinical trials and outcomes research in brachytherapy, please welcome with me Dr. Joy Ogumuyiwa. Please put your hands together for Dr. Joy. We're happy to have you. Please go ahead. Can you hear me, Dr. Ogumuyiwa?
Yes. Can you hear me?
Yes, I can hear you now. Fantastic. Thank you.
Good morning. Thank you for the wonderful introduction. I'm a radiation oncologist and currently a research fellow at Memorial Sloan Kettering. So for the past few months, I've had the great pleasure of working with the amazing team at NLCC, and I am excited today because I'll be able to very quickly highlight some of the research that has been coming out of this institution in this lightning session entitled Local Clinical Trials and Outcome Therapy. So the objectives for today, I just want to highlight some of the local projects coming out of NLCC. Sorry if you can you see my screen? Include CT image-guided brachytherapy, survivorship and toxicity issues after pelvic radiotherapy, the role of neoadjuvant chemo in the management of cervical cancer, and also a small project on AI-assisted radiotherapy workflow. So for the first study, it's a retrospective audit of the first 3D image-guided HDR guide brachy program in this launched in 2021 by Joseph et al. It was published in the Brachytherapy Journal. And it reviewed the first 24 cervical cancer patients treated on the program. And the goal was to assess target coverage, OAR, or organ at risk doses, treatment patterns, and changes in dosimetry over time. And they benchmarked this against the society guideline recommendations. So for key findings, overall, most patients achieved acceptable dosimetric outcomes. 71% of patients achieved a high-risk CTV D90 of greater than at least 80 gray, and most patients met and sigmoid dose constraints. A significant improvement over time. So the earlier cohort achieved a mean high-risk CTV of 77.5 gray, while the later cohort actually improved to nearly 89 gray, with 85 to 90 gray as the standard guideline to achieve adequate local control. So this suggests that there's increasing proficiency with growing clinical experience. So actually demonstrated the feasibility of a CT image based HDR brachytherapy program in Nigeria. And it also highlighted that how quality can improve with training, with experience, with standardization, and with on-field efforts. So at the same time, it also identified some challenges, so including prolonged treatment times, limited to no interstitial capability, and also MRI access was identified as a barrier. So of course, successful brachytherapy is not only about target coverage, as we've seen today. Pelvic radiotherapy and brachytherapy can result in significant short-term and long-term toxicities that can affect the patient quality of life and survivorship. So one area that remains understudied in this setting is vaginal toxicity and sexual dysfunction after treatment. So just a quick review from earlier today, we have acute versus late toxicities. It occurs within 90 days. It can include vaginal irritation, bleeding, dysuria, or procedural pain. And late can occur months to years after treatment. That includes vaginal stenosis, fibrosis, fistula formations, cystitis, or proctitis. And they often reflect pre-existing risk factors present at the time of brachytherapy. So extensive disease is a major one. So we are seeing less severe toxicity now, and that's due to image guidance, conformity can reduce long-term complication rates, and also it can actually optimize planning and reduce late morbidity versus the older approaches of brachytherapy. However, they still exist. So vaginal sexual toxicity includes stenosis, where you have a narrowing or shortening of the vaginal cuff. It can affect vaginal exams that are needed at follow-up, and it can also affect sexual function. Age greater than 50, lack of dilator use, and concomitant chemoradiation. So one of the management strategies that we recommend to patients who undergo brachytherapy, along with other treatment modalities, is vaginal dilator therapy. However, we were finding that many of our patients were not adhering to the recommendation for vaginal dilator use. So we did a qualitative study looking at the experiences with vaginal dilator therapy among gynecologic cancer survivors treated with pelvic radiation in Nigeria. So this study used semi-structured interviews to better understand barriers to use, facilitators to experiences with counseling and follow-up. And then Some of the key findings were barriers included pain and discomfort, of course. So one woman that we interviewed said that after the first session with the vaginal dilator, she noticed bleeding and immediately stopped. There was noted shame and awkwardness with discussing vaginal health. Limited understanding of purpose was also one that was commonly identified as a barrier. And then lack of follow-up support on behalf of the healthcare provider. Facilitators included clear provider counseling. So many of the women stated that when the provider explicitly talked about the vaginal dilator use at both last brachytherapy session and then the initial follow-ups, that they're more likely to use the vaginal dilator. And then also framing the dilator as medically necessary. So many of the women, so when the vaginal dilator was framed as a tool to help with sexual activity, it made them less likely to use the vaginal dilator. But when it was explained as a tool to help with vaginal exams that would be needed for follow-up in the future, they were more likely to use it. Also, family and spousal support were identified as facilitators, along with reinforcement and reminders by the healthcare provider. So why this matters? The study highlights that survivorship issues remain important but understudied issue in this setting. And then toxicity management extends beyond the treatment delivery alone. So when you have patient-centered counseling, culturally sensitive communication, and then implementation strategies that are locally informed, that can help really improve the long-term adherence and adherence to vaginal dilator therapy use, and also quality of life after pelvic radiotherapy. Ongoing, it hasn't become published yet, but neoadjuvant chemo has been explored as a strategy to reduce burden in cervical cancer patients, in locally advanced cervical cancer patients, to help improve treatment delivery. Historically, the role of neoadjuvant chemo before concurrent chemoradiation has been controversial. Some studies have reported mixed results regarding survival and disease control, but recent evidence from the Interlace trial demonstrated that neoadjuvant chemo can be helpful in this patient population, and it can significantly improve progression-free survival and reduce and overall survival as well in patients with locally advanced cervical cancer. But despite these findings, data on the feasibility and the clinical impact of this approach in Nigeria has been limited. So this study actually looked at the use of neoadjuvant chemo prior to chemoradiation and brachytherapy for locally advanced cervical cancer patients in Nigeria, and it's a pilot study. The primary question was whether neoadjuvant chemo could reduce tumor burden before definitive treatment. So key findings were that they found a significant reduction in tumor size after neoadjuvant chemo, with a mean tumor size from about 6 cm to 2.2 cm. And there's no significant increase in toxicity, although the study was small and not powered to detect survival differences. It's a good start from this pilot study. So the relevance to brachytherapy, large tumor burden remains a major challenge in many Nigerian patients who present with locally advanced disease, and tumor downstaging can be used to improve brachytherapy feasibility, target coverage, and treatment delivery. And then the last study, Wabi et al., published this year, and AI-assisted contouring tools in a Nigerian cancer center, and it was AI-assisted planning reduced the contour time for several disease sites and actually improved workflow efficiencies. Although barriers such as software licensing, infrastructure limitations, and technical training needs were identified. MLCC is one of the first institutions in Nigeria to use AI with route formation for contouring. As radiotherapy and brachytherapy services expand, workflow automation, like we heard earlier today with Dr. Ballman, may be able to help with addressing the workflow issues and planning bottlenecks that we see in these settings. So related ongoing work includes implementation projects evaluating AI-assisted workflow automation tools in Nigeria. Memorial Sloan Kettering actually is partnering with MD Anderson, using one of their AI-assisted automation tools, RPA, and we are looking to pilot that in a few clinics in Nigeria to see if there can be a significant impact on workflow efficiency. So overall, these studies highlight the growing body of locally driven brachytherapy and radiotherapy research in Nigeria, and they demonstrate the importance of implementation science, QI, survival, and it's used in helping improve cancer care delivery in Nigeria. Thank you.
Thank you very much, Dr. Ugumiwa. Exciting to have you present a lot of these studies that are generated out of our centers here in Nigeria. Thank you for the collaboration. Thank you for the effort. It's actually excited to see Luz Cancer Center just, churning out one study after the other. Very contemporary, relevant, timely. Please put your hands together for them. It's amazing. I'm so proud of Mama Brachy and all the other consultants in that department for the good work that they are doing. I would invite Dr. Adekwe to come and say who was after that, but I think we have 1 or 2 questions for you, Dr. Ugumiwa. Just kindly hold on as they tell you questions and answer them for us, please. Thank you.
Thank you very much for the presentation. Mine is regarding the use of neoadjuvant chemotherapy in locally advanced cervical cancers and the research that was conducted recently in MedSav Cancer Center. I think previously it has, but now with the interless study that was conducted and then coming down to our own centers, now seeing that there is benefit in doing neoadjuvant chemotherapy, especially if we look at the pathology of our tumors, bulky tumors. Sometimes even if you do the chemoradiation, you still have residual disease that you keep battling. What should I do next? And some other stuff like that. So I think there is still need to have more studies. Since we have 1 levels now, let's look at other centers that have external beam, and then they could do also brachytherapy to have exactly what we have in Lutz, so that we could compare. And then that's how I think protocols and so many guidelines will come, so that at least it can change our practice. Our patients are coming with bulky tumors, and there is need for us. Since we said toxicity-wise, this patient doesn't have much toxicities when we compare. So there is a need for us to do more researches with that regard. That's a call to all of us. Thank you.
Anyone else? Online, do we have any questions online? I haven't acknowledged people online. I'm so sorry. Thank you for joining us online if you're online. Do you have any response to that? It was basically a desire being expressed, Dr. Ugumiwa, for collaborative efforts with other centers outside of the loop, so that the effect can be far-reaching.
Yes, I completely agree. I think there's value in a lot of the research that's coming out of Nigeria. One of the highlights of Interlace was that it did look at patients from other LMIC settings. So there were patients from Mexico and Brazil, but there weren't any patients or institutions from sub-Saharan Africa. And I really feel like there is a lot of unique data that can come out of here. And I completely agree that collaboration with different centers, especially centers that are eager to do this kind of research is needed.
All right, thank you. So probably some of us will be reaching out to you and the team, they lose people to see how they can collaborate after now. So thank you for being there for us. Any other questions do we have? All right. Thank you very much, Dr. Gumiwa. Oh, Dr. Alikwiga wants you to hold on while she gives her comments, please.
Okay, so thank you once again, Joy. And so I just want to say briefly about this session we just had, our local work here. And okay, so Joy is looking so stressed. She had not slept since yesterday. She's presenting from New York. She had a board exam yesterday, and then she had to prepare her slides afterwards. I say thank you to you and wish you all the research fellow from MSK. So basically, after she, instead of going to other fellowship, she chose research, and she's doing that with Hago. And so that's why she's here with us. She's the first radiation oncologist in that series. It has always been medical oncologist or gynae oncologist. And so basically, we are trying to at least get more people to do that. And then during her stay with us, she's going to finish, she's coming back next week to finish her program, and she's finishing soon. But during our time, we have done lots and lots of work together. She has really helped our research. And so I want to use this opportunity to also appreciate the management of Medicine Booth, in person of Dr. Eko, Dr. Joseph, concerning our research. The research team has really, really helped us. So Dr. B, you see us turning our paper. It is, there's something on that, something that's making us to sound. And so I will also use the opportunity to appreciate Joy. And then Dr. Bola Alamu is there. She's a resident in UBTH, but she's a statistician guru. She knows so wonderfully well. So Missy is in my research team. She's supposed to be, I don't know why she's not, and Temitope and the host of others. They've done well, and they were really trying to see how much more we can do. So the first abstract she presented on vaginal dilator, it was a fallout of last year Brachytherapy Summit, when we had someone speak on vaginal dilator. And then after that, we have seen 2 of our patients coming in less than 6 months with severe vaginal stenosis. So before then, we were doing it approximately for some of our patients, and now we are institutionalizing it. So I'm telling us, we treat patients with any pelvic tumor, especially females. Your treatment is incomplete until you add vaginal dilator to it. That way, you are able to come. I learned this from Anuja a number of years back, that the best time is when your patient comes, you're able to do a pelvic examination. That's the best time you pick up it. That's the first time you won't pick up a recurrence. But the moment they come, they are not able to do that, you are losing out on something. So I want to tell our oncologist here, and as part of your care, put vaginal dilator. Then the second one about NACT. Unfortunately, what we did was such a very small pilot grant. We have applied for grants and we even reached out to other centers that are willing, we didn't get grants. But so with this one, apart from grants, we can actually do multi-center. Everybody follow the same protocol, and we're able to compare results. So we have a team, you know, at least anybody that's interested, let's come up. Let everybody, so we don't want squid data. We don't want you to forge data. If everybody's on the same page, if you are doing 3 weekly, I don't want a situation that those that are doing 3 weekly, let's get it recorded. Those that are doing weekly for this 6 time, let's do all of that and let's compare what we have. So anybody that is interested, we are willing and ready to partner on that. And then the AI, so thanks to Dr. Alabi, Dr. Isibo, and then a whole lot of AI. And then so one of the projects that Dr. Joy is also doing is that we want to test run this rat formation. It was supposed to be for medicine, then we are already using rat formation, so they are not ready to give us any free one. So we got other center, we got Kano, Abuja, and which other center? I can't remember the third one. Sokoto. So we want them to do a trial on the MD Anderson version for auto contouring. So we're just at the process of getting approval for data sharing, and so that way we'll be able to test it in those centers and see how well we can do. So once again, thank you all for this opportunity. Thank you, George.
So exciting times. If there's anything to take home from there, get yourself a research team. Because I think it's the way to go really. As doctors, we're very busy in the clinics, we're doing a lot. So from the loose experience, we can see that if every hospital had a research team, that you have ideas and then people can work together to make sure that they come to reality. Nevertheless, it doesn't take anything away from the brilliance of the Loop team and the good work that they have been able to do, as well as Dr. Joy Okumola. And congratulations in advance. I don't know how soon results come out. So fingers crossed, everything will be perfectly fine because you are clearly deserving of that. So all the best, and thank you for taking your time to attend with us. Cheers.
Thank you for having me. Thank you so much. It's been great working with this team here. It's a very, very prolific group.
Fantastic. Thank you. Right, so we're coming back home now, and we'll be moving on. Are we here? Are you with me? Yes, please put your hands together for yourself if you're having it. I see Dr. Rico, and I have to say thank you again because I mean this is fantastic. Even people who get brachytherapy, they learn past everybody for here. So just wait for it. I mean, just bring your machine out, just start inserting treating everybody. I cannot get more certification past this one now. What's it there? You know to do on that. They say puya. You will now check, then you attach. Until now, I'm good to go. So thank you. Please issue my certificate after. I think I'll go and push up. You know now. No, so I'm just kidding. It's just on the lighter note. I just feel like we needed that. It's been a lot of fun stuff, and too much stuff sometimes can just make you dull. So we'll be moving on now before lunch, and we'll have one more conversation that is going to stimulate questions, I hope. And it's a homegrown presentation because we're going to have Professor Yemi Okunowo, who is going to do an apt topic considering important HPV vaccination is in preventing cervical cancer. I mean, so let me just read you. Adebola Okunowo is an associate of Medicine, University of Lagos, and a honorary consultant gynecologic oncologist at the Lagos University Teaching Hospital. He's a fellow of the National Postgraduate Medical College of Nigeria, and because of brilliance, he decided to be a double-star general and is also a fellow of the West African College of Surgeons. So he pays two annual dues, which is a problem with these days. So congrats, you are well done, sir. We'll stay with our one-star general. Thank you very much. And so he's also he has advanced training in gynecologic oncology from institutions including the famous Tata Medical Center, the Sylvester Comprehensive Cancer Center, and Stanford University. He likes to focus on gynecological cancer prevention, clearly with this topic, and early detection, outcomes, and cancer genetics, alongside active involvement in research and training. Please welcome with me Professor Adeyemi Ademola Okunowo for this presentation.
All right. Hello. Hello. I think you should give yourself a round of applause. You've been seated for almost 1 hour now. It's not easy for adult education. For adults to sit down for how many hours listening. All right, so we'll be talking on HPV vaccination, and I'm sure during the course of just testing. All right, so during the course of our presentation so far, I'm sure you've heard a lot of things said about cervical cancer. Of course, treatment of cervical cancer is never complete without you guys. We work hand in hand most times. And of course, cervical cancer in this part of the world presents very late, 90%. Enough. In fact, in our clinic, because we normally collect some data regularly, the number of cervical cancer cases we see are not so plenty. Why? Not because they don't have to, because a lot of them get referred straight to the radio oncologists. And so, and the ones we see are just maybe advanced stage, yet to be diagnosed, then we make diagnosis, and then we just transit them to the to take care of them because they are all in advanced stage. But this shouldn't be so, right? And that's where the whole world is trying to do what? Eliminate cervical cancer. And one of the strategies to eliminate cervical cancer is vaccination, which Nigeria is key into. So we're talking about that, having an idea of what has been, then see how we can move forward as much as possible. So I will be using this outline. Oh, okay, it seems to be skipped. Okay, so I will look using this outline and will quickly run through what I have. So you see, cervical cancer, as we said, is a big tragedy, something that should never happen. And the sad thing is that happening to the female fold, who already have some, they somehow have some disadvantage in some areas because of where, especially sociocultural factors and other things. And it's very preventable. Yet, according to the World Health Director General, one woman dies of cervical cancer every 2 minutes globally. So just imagine as the clock ticks, a woman is dead of cervical cancer somewhere on the planet. And this shouldn't be, because it's highly preventable. It's preventable, it's detectable, it's treatable, it's accessible by any doctor to see. It's not hidden somewhere that something happens and you never know about it. Yet, it's the commonest gynecological cancer. Yet, it's presenting very, very, very late where it can be done. And that's why it's a very sad story in this part of the world. This is lagging there. Okay. Am I pointing in the right direction? Sorry, I don't know. Can you look at it?
Or change the slides for you.
All right. So, 9 in 10 cervical cancer deaths occur in low and middle income countries where we reside. So you can see that low and middle income countries account for the largest burden of cervical cancer worldwide. If you can remove them from the surface of the planet, I think already we have eliminated cervical cancer. So they are trying to eliminate cervical cancer because of us. All right? And Nigeria, the sad thing about it is that we contribute the largest proportion. Now, in the low and middle income countries, sub-Saharan Africa accounts for the largest, almost 94% of cases. All right? Now, in sub-Saharan Africa, Nigeria is a giant of Africa. All right. So, the largest contributor for new cases, incidents, the largest contributor for deaths from cervical cancer. So you can see in 2022 by the Global Health Statistics, there were about almost about 14,000 new cases of cervical cancer. And this accounts for about 12% of the whole sub-Saharan African nation. Deaths, we have the largest number of cervical cancer related deaths, 7,000 plus, and they accounted for about 9% in the whole sub-Saharan Africa. So Nigeria is the largest contributor to this burden of this disease. So, and the one thing that one thing that is good about cervical cancer is that, unlike other cancer, it's caused by an infectious agent. We know what causes it. It's not like one genetic mutation occurring somewhere that you don't know occurring sporously, that it just occurs and there's nothing you can do. Like we have ovarian cancer, whatever it is, you cannot, it's difficult to identify a definitive cause. But in cervical cancer, it's infection, HPV. And this infection is not just one sporous infection, persistent infection. It's there continuously for some time. Right? And one of the other things is that it has a pre-malignant phase. It doesn't just happen now, and then by tomorrow, something has happened, cancer has occurred. It runs 10 to 20 years before it can become cervical cancer. So it has pre-malignant phase. You have your low grade, high grade. It progresses, give you time shouting, I'm here, I'm here, I'm here. Yet nothing is done until it becomes cancer. Right? So, also because we know what causes it, we have been able to identify what can prevent it in terms of vaccination. So, if you give that vaccination, it can build your immunity against that infectious disease that will not run a persistent course that will cause cervical cancer. Now, HPV is a because infection. It's the most common sexually transmitted infection. Every person that is sexually active will have that infection one time or the other. Right? But is it persistence? It's continuous. Persistence means it's there for 6 months, 1 year, the same virus, the same serotype. But a lot of people, it comes and goes because our body immunity clears it out. So once it clears it out, fine. But the only problem is that the more sexually active you are, the more you acquire it. If you acquire one, it goes away, you acquire another one. There's a tendency that it can linger on for a longer period of time. And that's why people who are sexually active, sexual commercial workers, at increased risk because we get them to have more frequent infection. It clears out, it keeps coming. Not fight it and wait it off. So it's only a compromise that those things persist. So once the virus is there, we have that vaccination. We have there are two major HPV infection that causes 70% of cancers, just two, 16 and 18. And once you can protect yourself against that, you know that 70% you are covered. You only exposed about 30%. Luckily, with science, we have additional serotypes that we cover with our vaccination. And that's when you have the monovalent type that covers 16, 18, 31, 33, 45, 52, 58. And that adds additional 20% to it. So with that vaccination alone, 90% is covered. All right? Hopefully, with time, we'll be able to get vaccine that can cover almost 100%. And that is why, even if you have a vaccination now, you still have to do some follow-up screening because of that 20% risk of the one that is not covered. So you can miss the false positive or false negative. So you need to do it frequently, every 15 years. Until you've done it 2-3 times before you are so sure about that result. So, but with HPV, you know that once you test it is negative, it's very unlikely. And remember again, it takes almost 10 to 20 years for changes to turn negative. In the next 10 years, even if 10 is going to happen, you still be in the pre-malignant phase, you can catch it. So it's something that is easily adaptable and sustainable. So that is the strategy that remains cervical cancer. And that is what the WHO set out to achieve. So this just summarizes that strategy to show that primary prevention is through vaccination, screening, human papillomavirus testing, and then of course the tertiary treatment of precancerous lesions or cervical cancer, invasive cervical cancer. So how far has Nigeria gone with this strategy? This was in 2020. We're in 2026, 2030 for all countries to achieve this. And of course, we're happy to say that Nigeria has also taken the bull by the horn. Global emissions of cervical cancer. And to look at it, All right, Nigeria is one of the leading contributors to South Africa globally because Sub-Saharan Africa is a leading contributor, and in Sub-Saharan Africa we are the giant of it. So if nobody does anything, Nigeria should not sit back. All right. So this brought about the elimination for cervical cancer strategies that was done, that was on, starting with HPV. Matter is that if you can sustain, it's very, very challenging, but the cost of treatment. But at least, even if we are not treating everybody, we are preventing new ones from coming on board, so that it doesn't be a rolling stone that they keep coming. Cervical cancer, infection, cancer. We all have reports of people who develop cervical cancer. You can stop it. So that primary prevention is key and very important. And this was what Nigeria bought into. That in 2023, we were able to start that for 3 years afterwards. Start the process of elimination of cervical cancer through mass vaccination of young girls with human papillomavirus. And there are 3 types of vaccines of HPV available at the moment. We have the Severus, which is bivalent. It has just covers for the 16 and 18 alone. And then we have the tetravalent, that's Gardasil, which covers for both 16 and 18, and 6 and 11 that causes anogenital warts. Thereafter, we now have the Gardasil 9, which has covers for 2 of the viruses that causes anogenital warts, and additional 7 serotype that causes 90% of cervical cancer. So, the country is using the Gardasil, all right, tetravalent that covers both for 16, 18, and also 6 and 11, which is anogenital warts. And this was what Nigeria started on. And since 2023, when this started, or how did they even start from it? It was a 3-phase strategy for the national rollout and vaccination of young girls, 9 to 14, targeting them before they become sexually active. And the first phase was started in October 2023, targeting 15 states and the FCT. And the second phase was May 2024, targeting the additional remaining 21 states. So that by the end of May of 2024, all 36 states with FCT will have been covered in the mass vaccination of young girls with human papillomavirus. And then the last phase is now integrating this human papillomavirus vaccination into the routine immunization system, such that you've done a mass vaccination to catch and immunize the majority of people who have not vaccinated all this way. And then you're now integrating it so that every new persons who have not had this vaccination will continuously have the opportunity to have this vaccination into the routine, just like you do for polio. You go around and do all those vaccinations. That also has been part of what the state, the government of Nigeria is now doing to make sure it becomes a routine thing when you're now doing immunization. HPV vaccination is part of when you go from house to house, you should be able to say, oh, you're going to vaccinate young girls with this vaccine. So this is just a picture to show how it rolled out. How was the first lady with the Minister of Health in 2023, and it was in 2025 where they are trying to do outreach for all the immunization schedules, and also papillomavirus is also part of it. So what has been the achievement so far? So till date, since the time this was rolled out in 2023, we've had about more than 12 million young girls now vaccinated and receive 1 dose. That was scary. Because initially when HPV vaccination started, it came out with 3 doses. With time, science, right? 2 doses were considered, and then over a period of time, because of the fact that especially for developing countries where access to vaccine, cost, financing is an issue, the 1 dose came on board. And science have proven that 1 dose is as efficacious as 2 doses or 3 doses. Okay, so 1 dose is what is now recommended, especially for countries who cannot afford vaccination, or cost of vaccinating their population with those 2 or 3 doses. Right? So 1 dose vaccination is what is given. And then so within that time, more than 12 million young girls have been vaccinated thus far. All right. And Nigeria was able to achieve at least about 71% national non-personal vaccination coverage for young girls between age 9 and 14. Actually, when this started, it was a mass vaccination of non-personal virus ever recorded in any country at that time. Of course, you know Nigeria has a population. So, and you can see that previously, before that mass vaccination, the uptake of non-personal was just below 20, very low. Most people that take it are people who are well educated in the private sector, go to the private hospital, you are aware about it, I want to take it. It wasn't a common thing that people do. But now you can see that the difference. One, because it's available, it's cheap, and they make it available to communities to go and reach out to people who would have just come to the doctor or facilities opt for this vaccination. However, despite that this vaccination drive faced in that initial phase, which we will look at as we go on. A lot of low community awareness about it, logistical issues, vaccine hesitancy, reluctance to take vaccine, fear of vaccine, a lot of stories, a lot of theories that people who brought up that they are negative to people taking this vaccine. So this is an initial monumental achievement towards eliminating cervical cancer. However, the target is yet to be reached, and that is where we need to scale up. This was a statement attributed to the director of the National Primary Health Care Development Agency. That's actually the agency that's in charge of the mass vaccination of human papillomavirus. And he said our goal is 0 cervical cancer cases in Nigeria. True success will be when parents walk into the health facility asking for human papillomavirus for their daughters, and not being cajoled, going to their houses, come and take this, give them information, give them messages to cajole them to take it. But by themselves, say, yes, I heard that there's vaccination, I would like to have it. That is what we are hoping to achieve in the long term. So scaling up, there is need for sustainable human papillomavirus vaccination, and this requires multi-sectoral collaboration across board: federal government, state government, local government, right? Donors, right? Healthcare workers, stakeholders, the community themselves, the parents, the community people, because it's one thing to make things available, it's another thing to say, no, I don't want it. Convincing them to have it. So trust is very important, strong local leadership is very important, sustained political will. You can see that with political will, all things are what? Possible. Within 2 years, we were able to achieve more than 12 million vaccination. Why? Because of political will. We started from the WHO, trickled down to all member countries, and every country around with it. So we need that for moving on forward to make it a sustainable program, just like we have the routine immunization program that sustains itself, keeps rolling and rolling and rolling. Remember how polio was eradicated? Continue political will, continue going to community, regular vaccination of people until we recorded 0 white polio virus infection. So policy reform very important to ensure equity. That was one of the key things. And equity, vaccine equity simply means people who need the vaccine get the vaccine, not people who don't need it. For example, people in the rural areas that need the vaccine and vaccine domicile in the urban area are not getting the vaccine just because they have the money or the purposes to have it. Equity means vaccine getting to who is where it's needed and they have access to it at every point in time. And that is key in moving forward and sustaining this program as much as possible. So inclusion and equity very key. So evidence-informed advocacy to strengthen HPV vaccination. You need to have evidence. Look, what are the communities saying? What are people saying? What are their worries? What are their challenges? And then address it at the grassroots. Meet them at their point of need. You can take the camel to the river, but you cannot force it to drink water. All right? So you can make things available and turn their back and say no, because we don't believe in it. So we need evidence-based. What are the challenges? Data-driven. That in these reasons why vaccine resistance is high in this area because of this, and this. And then there are targeted interventions to address such as much as possible. Stakeholder engagement collaboration, very, very important. From the government to the healthcare workers, collaboration between states and subnationals. All right, both donors, all are very important. Community, every level, every people involved in ensuring that HPV vaccination comes to stay as much as possible. Not that after 2030, when you seem to have achieved it, everything dies and everything goes back to where parliament started. No, continuous sustainability. And that one will bring about eradication of this cervical cancer. Availability and sustainability of the vaccine itself, very important. The rollout was based on donor. About more than 8 million vaccines were donated by Gavi. And Vaccine Alliance also donated almost 11 million vaccines for inclusion into routine immunization. But this will not always continue. Initially, this rollout was meant to have happened some years back, but COVID came, disrupted things. Focus shifted from HPV vaccination to COVID vaccine. So there was a lot of delay. But Nigeria cannot continually depend on donor-driven supply of vaccination. So availability and sustainability of vaccine is very important. Domestic innovations on how to do this. And this may include even making own drive production of this vaccine, or having alliance and partnership that will help produce these vaccines at cheaper rates for the country, or even having it developed even in Nigeria as much as possible. All this will bring about more access and availability of this vaccination for people that will need it. So adequate financing with established budget line, very important, because as we said, donors cannot continue financing it. So we need to be able to have dedicated finances to be able to run this HPV vaccination as much as possible, just as we do for the routine immunization schedules for our children. But also have an innovative way of financing this vaccine and making it available as much as possible. So this just shows the economics of cervical cancer. You can see that just to vaccinate a young girl, it's just about 10,000 to about 15,000, 20,000 naira per dose. But for someone that has cervical cancer, cost of treatment is almost going to about 8 million. We see it a lot in our clinics. A lot of women that come in advanced cervical cancer, poor, indigent. You can do nothing. Write letter, go to the therapy. They just take the letter in their pocket and go home and go and sit. Because they cannot afford it. They come to Mensa, they cannot afford the cost. So that's an issue, a huge issue that we need to deal with. So you can see that prevention indeed is what better than cure. So just 20,000 or most 20,000 or 10,000 to have a vaccine that can protect you than to have cervical cancer. We're looking for about 8 million or plus to treat that you cannot even cure. So educating mothers is very important because mothers are the gatekeepers of the home. Right? For adolescents and young girls we are going to be giving targeting vaccine, they are what minors. They need consent. It's only their parents that can give that consent. So the parent says no, no is what? Is no. So we need to educate mothers, especially mothers and parents, on the importance of the HPV vaccination and the need for them to allow their children to have this vaccination. So their support is very pivotal in it. Because to assess, you need to give them access to accurate information, disable their minds with the myths, cultural and religious biases, and then understand that prevention is better than cure. One of the challenges is that they believe that vaccination affects fertility. So once you give vaccination, you have destroyed our girls' child's fertility. And of course, you know that childbirth has premium in this part of the world. Pregnancy, childbirth. That in the right senses and allow a child to go. So you need to disabuse that myth as much as possible. So you need to target mother and let them know, support their role, let them know that you understand their children and that this, of giving vaccination to these young girls is protecting their future against cervical cancer. As long as a person is sexually active, which is very, very, very likely everyone will be, there is a risk of having this kind of issue. Community leaders and gatekeepers of the community are very key because they deal with people in the community. What they say at times is final. When they say something, don't go there, that's the end of it. You say go there, they will just, without me, decide you should go there. Right? So they are very, so we need to engage them. So we should do a bottom up, not from up down. Bottom up, get them along. Once you carry them along from the bottom, they will help the drive. They be the one championing it as much as possible. But when you come and you want to impose it on them, that's when they look back and say, they have come again. But when you carry them along right from time, educate them, sit there, let them understand what is the need for it, the importance of it, they will run with it as much as possible. So we need to include religious leaders, chiefs, traditional healers, local influencers, respected members of communities. These are all people that people will listen to. That when they say yes, just like religious leader, you go to the church, the pastor says, go and collect this all because the pastor said so. So they believe the pastor has knowledge. It's just like you with your patient-doctor relationship. Whatever the doctor says to the patient, it's very likely that the patient will do it because the doctor said so. So also are these community leaders. Right? So because these community leaders themselves, they understand the culture, they are part of the culture. So they can understand, go around the culture to convince the people to see the reason why they need to do this against what they are saying. Right? And they respect their opinion. So they can help promote HPV vaccination, address all the concerns that we have, encourage uptake, while advancing their cultural sensitivity. They can balance the two together. Once you have someone that can balance the two and what their culture or religious something is, and they can merge the two and communicate with the people, they can see that it will be like a mob. Because people believe in messages affected by who delivers it. As we said, when the doctor says something, and someone that is not a doctor, a neighbor that says something, they will not believe that. But because the doctor said it, it's very doctor that they trust and they believe that this doctor, oh, it's like my God, he has done so well for what the doctor said. So once you have that, it's easy for them to drive with it as much as possible. So engaging the community itself, but you start with the community leaders and then you engage the community. You cannot engage the community without community leaders. But you know they are the gatekeepers of the community. You must carry them along. And once you can engage the community, then you're able to accept whatever you are saying. When they have seen somebody that they respect, believing what you are saying, telling them even more than what you are saying, explain to them, convincing them to see the importance of it. So you can now see that build trust in vaccination services, increase vaccine awareness, and then reduce the hesitance that people have. You don't need to even convince them. You tell them, no, they've told us, we believe you. And trust, I've convinced them. And ultimately increase the uptake of HPV vaccination. So this is just a diagram trying to show how and organizations all come together to increase the awareness of HPV vaccination that eventually leads to uptake of the vaccination. Right? So these are all things that must work together to make sure that we can now escalate it, scale it to a higher level, that every person will be able to partake of it. Also, parents teacher association is very important because school-based HPV vaccination is also very important. But the issue is that in our part of the world, currently we have about 20 million out of school children. A lot of our young girls are out of school. 50% of the young girls are out of school, especially in the basic education line. So that is why, apart from, you can see that in most of all the advanced countries, school-based, but a lot of them, the children go to school. That's the place where they can catch them. But a lot of out of school, and that's why campaign outreaches is still very important. Going to all these different places, because you will not meet everybody in school. But those in school, you should also target them. And how you can target them is through this parent teacher association as much as possible. Alright, you grant them information, let them understand, they're educated. All they need for them to see the reason and understand the importance of human papillomavirus, and they'll key into it as much as possible. And then that proportion of people in school are already covered. They are not dealing with people who are already out of school, who are in the community, that are doing outreaches to make sure that you get them as much as possible. So this set of people is important in scaling up HPV vaccination in the country. So these are some of the barriers highlighted and identified. It's what? Access at high cost. And that is what the mass vaccination overcame by giving it free. Because most people cannot afford the cost of it. So we can make it affordable, accessible, as much as people, you have a lot of people access it and willing to accept those who want to. So awareness, we need to build on the awareness, continue building on it, right, to make sure that most of our mothers, the community people are aware of the importance of human papillomavirus vaccination, and they can easily keep into it. Cultural and religious concern, when misinformation occurs, very important. Because a lot of our cultures and religious something forbids anything unnecessary with infertility. So when you're able to deal with that, a lot of the challenges you have will be reduced as much as possible. So we need to key the religious leaders, our community leaders, to help with this information. Because a lot of people believe, traditionally by default, vaccination is contraception. Perception. If you receive vaccination, that's the end. Nothing will happen again. That's a perception. And we need to deal with that as much as possible. Mistrust, myth and conspiracy theories, education, enlightenment, campaign, will all help in doing this as much as possible. TV, radio, media, even meeting religious leaders so that they can speak in their groups, women leaders, all these people will help to address this conspiracy theory. Then also strengthening of the health system infrastructure, availability of vaccine, cold chain, personnel, transportation. These are all things that are challenges that needs to be dealt with. And when all these things are dealt with, it will increase access of vaccine to the hinterlands, to the rural areas as much as possible. So it will be restricted to the urban areas when all these challenges are not there. Outreaches versus facility-based is one of the things we talk about. Facility-based, people only come to the facilities and walk into the facility, that's the goal. Walking to the facilities to come and get this vaccine. So you have to go to outreaches to where they are. Just like we used to do the home, all these immunizations when they go home to home, knocking on people who have received this measles vaccination, polio vaccination, just because people will not readily walk to the community or to the facility and have this vaccine until we get to that stage. So outreaches are very, very important in this. Data on adolescent cohort is scarce. We barely can have, even for that age group, 9 to 14, it's difficult to have data that this in Nigeria, this is a particular for 9 to 14. So that is a challenge. Even when I was researching for this, what is the total population of young adolescents, 9 to 14? It's difficult. We have different data. Adolescent, we don't have that, so we need to build data, and that data will help us in our evaluation of the program. Financial sustainability, we talk about dedicated budget line, financing by government is very important to sustain this on the long term. Equity gap, as I said about vaccine equity, very important. Vaccine must get to those that need it, the marginalized ones, those humanitarian settings, IDP camps, right? Those who are normally undeserved population and not just reside within the urban areas where people can easily access it. And that is very key to make sure that the vaccination gets to everywhere that is necessary. That's where we have rural versus urban hesitancy, and this is due to different factors. Right? Urban, mainly, you have people, but you know that when you're educated and you're ignorant and you believe you know, it's difficult to change your mind. So a lot of challenges, modes of all those kind of dissemination of those ignorance come through social media, WhatsApp, Facebook, which you will not see in the rural area. Those rural areas will learn about community. Once their leader says this, they believe it. But in the urban area, there's not like once the leader says this, everybody is his own God, so to speak. Perspective. So the challenges you have in is slightly different. So that's why you need information-driven advocacy, and not just apply one post or not fit all. Non-government agencies, NGOs, media, community leaders is essential in overcoming most of all these barriers. Multi-sectoral collaboration is key as much as possible. And moving beyond of this program is sustainability of the program itself, so that it can run by itself. As you scale up, you have to reach more, cover more grounds, cover more population of target population, and then for it to run and sustain itself is one of the things we're going to be looking at after you scale up this project. And then you're not looking at not just the coverage metric, but now looking at equity outcomes. Yes, you can cover almost about 90% of young girls 9 to 14. But those in the rural area, those in the IDPs, are they neglected? So that by the time you have scaled up, you can now be looking at equity outcomes that all the underserved, every person that needs the human papillomavirus has access to it as much as possible. And that is when real sustainability actually occurs. So it means that the healthy and the thriving world without cervical cancer is possible if we all strive to eliminate cervical cancer. Thank you.
Great stuff. Oh, thank you very much, sir. I mean, that was very well researched presentation with all of the details that you would please take some questions if we have any questions. That was brilliant in every way. I mean, already so many hands up, sir. All right, let's just quickly have them ask the questions, and then please I will just take 3. Oh my. All right. Should we just quickly take all the questions? Would you have them? Let me give you something to write down. Please make your questions brief. So let's make the questions brief. I'll just walk around. 1 question per person. Don't come and do 3 questions.
Thank you very much, sir, for the presentation. I would love to ask, you made mention of things put in place to target the adolescents, but are there any strategies to target young adults, especially the age of 20 to 40? Because this particular persons comprise of the most sexually active females. So that's my question, sir.
This is more of a clarification. You said young girl with HPV should be vaccinated. So, like, do you have to test them for HPV before you vaccinate them? Okay, in your presentation, I heard you said young girl with HPV should be vaccinated. So I was like looking at it. Do you not have to do HPV testing for them before you give them vaccine? So I just wanted to clarify that.
Thank you very much, sir, for the presentation. My question is, this vaccine, is it for life, irrespective of whether between doses? Because I came across somebody who got vaccinated some years back. Then she made herself available again after some time for cervical screening, and she tested positive. So, do we need a booster dose or something?
Thank you, Professor Yemi, for that wonderful presentation. Even though I'm young and young in this profession, with the little patients I've seen some patients who come down with cervical cancer at early victims and early 20s. I was surprised. You said there's a gap of 18 years if somebody have HPV infestation. So why are they having cervical cancer early at that age?
Thank you very much, sir. Thank you very much, sir, for the lecture. I just want to get some clarification on what we see in clinic. Like sometimes we see women coming with their sisters, with their daughters, some of whom might already be in their middle to late 30s, and sometimes they ask, especially like among the daughters, that they are not sexually active, have never been sexually active, but have never gotten the vaccine. So my question is at that age range, if upon the request, would it be advisable or allowable to give the vaccines? Thank you.
Thank you for your presentation. How readily available is the HPV vaccine? Has it been incorporated into the NPI? And is it available across the country now?
Okay, thank you very much, Prof, for the very interesting lecture. Okay, my hope is to say this. Prof, as of 1960, based on the history, the population of Nigeria was around 45 million. And it's been projected by UNFPA that the population of Nigeria will rise to about 450 million by 2050. 2050. That's the year 2050. So it means that it will have risen by times 10 the population as we had at independence, 1960. So after 2030, the WHO put as the cutoff year. So what happens next after that? Because the population of Nigeria is still growing rapidly with the fertility rate that we have right now. Because it's been projected that we are going to have 450 million by 2050. So meaning that Nigeria will be like the third most populous country behind India and China. So what efforts is still going to be put in place over time? Thank you, sir.
And then Dr. Polasri, last question.
Yeah, thank you. Even though some people have part of the questions have been answered, I want to ask, If an adult takes this vaccine without being checked for HPV, what would happen? That's it.
Okay, yeah, thank you very much. Those are all excellent questions. It shows that you were following. All right, let me start with the last question. Now, I'm sorry if I said, I can't remember saying it, but I said that adolescent that has HPV infection should be given vaccination. I can't remember saying that. If I said that, I think that's wrong. Yes, but I can't remember saying that. But I shouldn't. Okay, the HPV is just like saying somebody that has measles or something, you're not giving measles vaccination. You give it, vaccination is for prevention, primary prevention, before you're even exposed. Screening is that you're already exposed, but you're trying to detect early onset. All right? So that's what they're saying, between the age of 9 to 14. Before, except at the age of 9, the girl child has been assaulted or violated or some other thing, exposed to sexual activity, which is unlikely, but we know that nothing is impossible. So that's why we say between 9 and 14, before age onset of sexual activities. That is when the vaccine is better like any other vaccine. It builds your immunity so that when it comes, you're exposed to the worst of the infection as quickly as possible. Right? So that means you do not need to do HPV testing for HPV vaccination. Even for people who have been sexually active. Now, the target is 9 to 14. Doesn't mean that after 14 you cannot have it. You can. Okay? But just that it won't be as effective as when you have had it before exposure. Alright? Even some people after by the age of 40, it is subject to, but you should know that this one you are taking may not. If you're already exposed already start having precancerous lesions, something is happening, then the vaccine will not reverse it. Okay? But if you have been exposed, but luckily nothing has happened and not caused any change, it doesn't mean that because you're exposed, something must happen to you. Remember, it's the most common sexually transmitted infection. It's only when it's persistent. So if you have not been unduly exposed to sexual activity, maybe having multiple sexual partner or partner multiple sexual partner, then the tendency that even if you are exposed to it, your body will ward off, except if there's some other immunocompromise. Or the infection is so virulent and so frequent, as your body is going off, another one is coming, the tendency of you, that thing happening, changes in occurrence will occur. So if you have been exposed and luckily nothing has happened, you take vaccine to prevent you from further, when you're exposed, further exposure. But whatever has happened for you took the vaccine, it cannot change it. And that is why, even when you have taken the vaccine for everything, remember it covers only about 90% of cases of HPV that cause cancer. The other 20% are not so common, but they can still occur. That's why you must continue your screening, all right, to detect if there's anything until you're able to get a vaccine that can virtually cover almost 100%. Then you can now say you want to do screening again. But as long as it's not 100% coverage, then possibility of further continuous screening is important. So at the very few that you are not covered for, if there's anything you can. But remember, 90 out of 100 is almost as if you are protected. But of course, we know that anything can still happen. But the risk is very, very, very low. So there's no need to do any screening tests and tests for MAPA when you are doing HPV vaccination. Okay, as long as we did that target age group, and even to those, there's even a catch-up up to 26 for those who miss that target. You can still vaccinate. Even those who have passed that and they desire to have it, but for you to let them know that the protection is no longer as effective as it should be. But they can still say that someone to have it. It doesn't mean that it will harm you. No. Right? Luckily, if not as it can protect, but if you're already exposed, but your screening is more important at that stage than just vaccination alone. Do you understand that? Okay, regarding your question regarding population growth and expansion. Yes, the elimination strategy is not related to population. That's why it must be a sustainable thing. Okay, the target is that by 2030, countries should have attained almost. If you have attained it assumes that you continue. Not that you attend and now go back and say, sit down and attend it, then you now drop. With population expansion, those who have taken the vaccination, they have new people who have not taken. No, you now maintain. That's why they say that minimum of less than 4 per 100,000 cases of cervical cancer must reach and maintain. All right. So, but then it's for you to get to the yardstick, yes, but of course you have to maintain it. There continue vaccination, and that's why the sex must be entrenched in the routine immunization. So once the entrenched, becomes part and parcel of the process. Just like for children that having, when the child is born, by default, you have to give vaccine, except something's wrong with the parents or the child is born in the bush. All right, but by default, you know that this child must normal routine by default. So it becomes so now by default. Okay, even though that there may be some people who may have that's why you see people still doing that outreaches. They go to house from house to house, make sure that vaccination, have you taking your child has measles, have your DPT, has other one. They still go from house to house because they know that there will be some few people, because utilization of healthcare facility is not so good. So we want to go to all those, so make sure people that don't come, you go and meet them and make sure they get it. One of the reasons how cervical cancer have been eliminated in the developed world is that they call you even to remind you about your screening test. They won't say that because you didn't come to hospital, don't do that. They will give you a phone call, you are due for your pap smear. Even if you forgot, they will remind you. You don't come again, after I want to call you again. And that's why cervical cancer was somehow reduced significantly, even with just pap smear. At that time, there was no HPV testing because of regular established screening system. And that's what the WHO expect every country should attain. All right. So, so as I said, for 20 to 40 years of age, as I have said it before, even if you miss that 9 to 14, when you're sexual, you can still have the vaccination. But it's just that, but again, it's not compulsory that before you have to go and do pap smear, make sure that nothing is happening. You don't do that. All right. You can still have it, but they only be aware that the full protection cannot be guaranteed against exposed. What is most important, most of the exposed, is your screening. All right, make sure that your regular HPV screening, your past screening, you do regularly as much as possible. All right. Then, so young girl, going to test young girl for HPV. That was a slip of tongue. So I can't remember saying that. So you do. So it's not young girls with HPV that you give HPV vaccination. You give it to young girls who are yet to be exposed. All right? And even if they are exposed, whatever it is, you can still benefit from it. Okay? They may be exposed to one subtype, and you have another, for your vaccination, you have about 7 subtypes, the common one that covers 90%. All right? You can be exposed to one that you have it. Exposure is different from progression or whatever it is. Okay? So don't say, you don't have access, so you cannot qualify. No. The progression of HPV infection. So duration of vaccination efficacy is for life. So you don't need to be calling for booster dose that have took you 10 years ago. No, once you have it, it covers you for life. So there's no need for booster dose to come and take afterwards. Okay, early onset. Yes, for those that have early onset. Yes, remember I said that HPV it's a we call it mandatory cause of cervical cancer. But that mandate has a caveat. Not all cervical cancers are HPV related. We have very few, 2 to 5%, that are not HPV related. If we do any no. All right? And those ones can still have cervical cancer. But the majority of cervical cancers are HPV related. So those ones that have early onset of cervical cancer, you need to probe further. Because one of them may be evaluated early in life, exposure, or already exposed to the HPV infection early in life, or they're immunocompromised. Once you're immunocompromised, what I know HIV, that is called HIV. Your body ability to fight that infection is withdrawn. It's destroyed. So the virus has a free day to cause whatever it wants to cause. Only God will save you from it not causing anything. All right. So, I think, early onset, is that, I think that's all. I'm not sure there's any other.
Thank you very much, sir. We're really grateful. Obviously, the number of questions are an indication of. Say, you want to make a comment? Oh, okay, sure. We must extend that courtesy.
Oh, thank you. It's a wonderful discussion on HPV vaccination. I just want to add one thing regarding the discussion on the age. So as you all know, HPV is a virus. So virus, the immunity is cell-mediated immunity, especially the T cell immunity. So T cells are named T cells because they mature in the thymus. The thymus gland will shrink after the age of 15 years. So the best effect is before 15 years. That is when the thymus is active. So there will be lifelong immunity. Even the evidence for effectiveness of vaccination in adults is not very strong. So we don't usually recommend it for adults, but for young children, definitely yes.
Thank you very much for that additional information. It really adds up. We would like to thank you, Prof, for doing justice. You pieces that thing with so much, and that's what caused the generation of questions, So we're really grateful. Thank you for taking the time to speak to us. So we're going to go for lunch break. I would like to preview your indulgence so that there won't be so much of a crowd. We'll go table by table, starting from the front. So wait for the person coordinating to tell your table to move before you go outside. While we're going for that, I would like to recognize the presence of Professor Showumi, Dr. Abib, and Dr. Folashiri, who are very senior radiation and clinical oncologists in our midst. Thank you for your presence. I should have recognized you earlier, and I apologize. Prof, you can go with this group. Thank you. All right. So please, everybody, just a little bit of patience so that it can flow with ease. Okay. So yeah, just follow the leading of Dr. Adebuega, and then we'll be going to have our lunch. And if you need a bio break, now will be a perfect time. Thank you, everybody. You've been fabulous. So they'll be coming around to get us in just a short while. There's already a crowd outside, so we need to be a little bit patient. Don't worry, they are handling it better than so you'll be fine. Everybody will be fine. I know I'm just
ẹ jẹ́ kí ọ̀rọ̀ amínú ọmọ kéèkì tó bá wà kódà tó bá wà ní kódà ọ̀pọ̀ ló.
So, you know, it's Lagos, what I say? It's we need to Lagos to beyond. but you got an Yeah. That's the thing. Come back on the 26th. So flexible. Okay, so what you see, okay, what you call 3%. Okay, so 3%. Okay, this is we are going to be but this is go and go. But we understand this is very hard. Oh, okay. What they do is they go to otherwise I'm not for it.
All right, ladies and gentlemen, we have 2 more minutes and then we'll be starting. Please wrap up your meal. I hope you've had a good one. Let's move full speed ahead so that we can wrap up in due course. And I'm trusting that this summit has been very enriching and has helped a lot of us to improve our practices. That when we go back to where we primarily practice, there will be some positive change. So, Dr. Oshika, will you please be ready for your presentation? 2 more minutes, ladies and gentlemen, 2 more minutes. Is our presenter in the room? I don't see Dr. Oshika. Oshikolu. Is she in the room? Older. Please let everyone outside come inside. We're about to start. On the all right, ladies and gentlemen, we'll be moving on just about now. Our next presenter is Dr. Oshikolu. And she's going to be talking to us about the advantages.
What's the name of What's the name of file? It's a trouble. What's the name of file?
Okay, so she's in the house now. I will introduce you formally. So our next topic is management of acute and late toxicities of treatment. Oh. Dr. Bukola Oshikalu is going to be our speaker, and so Dr. Bukola Oshikanlu is a consultant radiation and clinical oncologist at the Medserv Luth Cancer Center with over a decade of experience in cancer care. She trained at University of Lagos and completed her residency at Lagos University Teaching Hospital. She is a fellow of the West African College of Surgeons with clinical interest spanning gynae, genitourinary, breast, head and neck, and gastrointestinal and skin cancers. She's an active member of ARCON and ASCO and AORTIC and the Nigerian um, Medical Association. Please welcome with me Dr. Bukola Oshikanlu as she makes her presentation on the management of acute and late toxicities of treatment. You're very welcome, madam.
Thank you, sir. Good afternoon, everyone. Please, can I have my slides? Okay. Okay, thank you. So, good afternoon, everyone, again. So, we're talking about the management of acute and late toxicities of brachytherapy. Now, some of the symptoms or things I'll mention may not be directly from brachytherapy. We need to bear in mind that patients, most of them would have already had external beam radiotherapy before coming to us. So the fact that they are now having brachytherapy doesn't exclude some of those symptoms that would have arisen from the external beam radiation that they had prior to coming to us. So we'll be using this outline. So management of side effects, it focuses on minimizing toxicity to surrounding healthy tissues like the rectum, the bladder, and vaginal mucosa through precise 3D imaging, specialized applicators, and prompt symptom management. So most of the presenters earlier have talked about precise 3D imaging and specialized applicators that we can use to minimize toxicity from brachytherapy. So most of what I'll be doing, or my talk, will be on the side effects or symptoms we can have of toxicity and how to manage them. It is imperative that supportive care is integrated, not only throughout, that integrative care is, that supportive care is integrated throughout treatment and should commence, right from the diagnosis and should continue after treatment is completed while the patient is on follow-on care. So CTCAE grading, it guides severity and management. CTCAE stands for Common Terminology Criteria for Adverse Events. I didn't so much infuse this into my slides, so I'll just mention its relevance in one or two. You can use it for most adverse events that arise from our treatments, but I'll just mention them briefly, especially when we come to talk about diarrhea, but it's important that we know about it. The latest version of it was released sometime in July last year, and that's version 6. So prevention and early detection. Excuse me, I've asked for water, but not yet. Sorry about that. So continue. So prevention and early detection are essential, and radiation effects are commonly divided into two categories, early and late. And these effects can further be categorized according to the organ system from which it is arising. Okay. So for the acute effects, they usually emerge within the first 6 months post-radiotherapy, and they affect rapidly proliferating tissues, can result in erythema, mucosal inflammation,
an acute discomfort. Thank you. An acute discomfort. They're usually reversible and result in deterministic radiation effects. That deterministic radiation effects are dose dependent and they follow predictable threshold response. So for the late effects, they arise within 6 months post-treatment to years post-treatment. They involve slowly renewing tissues, are frequently irreversible. The onset is usually insidious and their severity unpredictable. Because they are reversible, that's where it's important that we prevent them as much as possible. So the late effects also are influenced by both deterministic and stochastic mechanisms. They may be difficult to distinguish clinically from tumor recurrence, and they can manifest as ulcerations, fibrosis, or fistulae. So multidisciplinary care is very important in managing toxicity from brachytherapy, by extension, radiotherapy. So it would involve radiation oncologist, the medical oncologist, the nurse, the therapy radiographer, dietitian, the social worker, the pelvic floor physiotherapist, the psychologist. Where available, we should also involve a sexual or a sex therapist because of the sexual dysfunction that may result from our treatments. So for acute side effects from the rectum, the commonest urgency and cause discharge. Sorry. Please excuse me, thank you. So for diarrhea, according to CTCAE I mentioned earlier, it's graded 1 to 5. Most of the symptoms are graded 1 to 5. So 5 usually means death. 4 would mean that hospital admission is required. So with diarrhea specifically, grade 3 diarrhea means the passage of frequent loose stools more than 7 times, and then grade 2 is 4 to 7 times, and grade 1 is 4 or less times. Okay, so for diarrhea specifically. So tenesmus is the urge to pass stool. You know, the patient feels, oh, I'm pressed, rushes to the toilet, but nothing comes out. That is tenesmus. It can be an acute side effect, and as we see, it can also be a chronic or elite side effect. Urgency as well. Patient is pressed to pass stool and will need to go urgently, otherwise she or he would soil himself. Okay, so you can also have mucus discharge as well from the rectum. So for diarrhea or enteritis, management will include counseling the patient on low residue diet, especially while the patient is on treatment, so that you can mitigate the patient coming down with very furious diarrhea that would be so troublesome that treatment may have to be interrupted. So also, if it's like grade 1, grade 2 diarrhea, we can use loperamide tablets. That's usually the first line anti-diarrhea medication that we should prescribe. So when you prescribe loperamide and the patient is not achieving any relief or symptom control, we can then go on to Lomotil. And sadly, Lomotil I find is scarce these days. Recently, I've had patients with troublesome diarrhea, prescribed loperamide for them. For 1 2 weeks, diarrhea still persists. I tell them go look for Lomotil, and it's not been available. I've actually had to check myself and still at some pharmacies, and Lomotil wasn't available. So if we have drug reps here, I don't know what's going on with Lomotil. It's a good drug that we need for controlling diarrhea from our treatment. So hydration as well is also very important. Hydration. So for hydration, I tell patients usually should be like 3 to 4 liters per day. Some people will say 2 to 4 liters per day. But usually I emphasize to my patients they should take minimum 3 liters of water every day. So that would help them cope with any diarrhea side effect that they may have from their treatment. So it's also important to rule out infection, because the patient is having radiotherapy and has developed diarrhea. We should bear in mind that most of our patients come to us from out of town. So their food, they're not responsible for making their own food. So they have to buy food from food vendors, and sometimes they may actually have food poisoning, which can present with diarrhea. So we shouldn't just attribute our diarrhea to just radiotherapy. So we can also rule out infection where necessary, especially if it is persisting despite loperamide and Lomotil where it is available. So some patients may also have nausea, vomiting. Remember I mentioned patients before coming to us for brachytherapy may have had or would have had external beam radiation. So nausea, vomiting not directly from brachytherapy because it's meant to be targeted to the cervix and while sparing surrounding normal tissues. So for nausea and vomiting, you can use ondansetron tablets, metoclopramide, and you can also encourage the patient to take small frequent meals. This advice of small frequent meals is especially important when patients are complaining about bloating, which would again be from external pain rather than from brachytherapy. So for chronic side effects from the rectum, we see diarrhea again. So diarrhea can be acute and it can be chronic. So chronic, it will be lasting from anywhere from 6 weeks and beyond post-treatment. So we can also have tenesmus as well as a chronic side effect. Erectile bleeding, this one can be very, very troublesome to the patient, and it's called telangiectasia. And sometimes with rectal bleeds, we shouldn't, initially you would counsel the patient to say, well, it's most likely from the radiotherapy. But rather than just, assume it's from radiotherapy, especially if it persists after you've given, steroid enemas or you prescribed, steroid suppositories, for example, and still it is persistent. The patient may actually need to have a colonoscopy done to rule out secondary, to rule out asynchronous or metachronous primary malignancy from the gastrointestinal tract. So again, for chronic or late side effects, you can have excessive flatulence, you can also have fecal incontinence, you can have fistula formation. Fistula, you can also have enterovaginal fistula or enterocutaneous fistula formation. So patients who are more at risk for these fistulous conditions are usually those that come to us with very advanced disease and they are not able to have their diseases downstage. For example, a patient coming with like stage 4A cervical cancer with involvement of both bladder and rectum, and you counsel the patient that, oh, you're going to need some downstaging with no adjuvant chemotherapy. But the patient cries out, oh, I do not have money. Go ahead to chemoradiation. Like one of the patients that we used for brachytherapy yesterday, who is incidentally my patient, her disease was stage 4. I counseled her to have chemoradiation, but she turned it down owing to financial constraints. So we had to proceed with chemoradiation for her, and thankfully she's responded well. However, I did counsel her that there's a risk of fistula formation, and it is a late side effect. So right now she's still in the acute phase of her treatment, so it hasn't come up yet. So if further down the future it does come up, she'll definitely remember that I mentioned to her that there's a risk of fistula formation because her disease is quite advanced and we're moving up straight to having or giving her chemoradiation therapy. So another chronic side effect can be intestinal stricture. So the management of late toxicities would include steroid or sucralfate enemas, like I mentioned, and the hyperbaric oxygen one. It's right now not available anywhere in Nigeria. So I've read about it in some studies that have been done, and most of the studies done were outside the country, and they said it did improve the late or chronic toxicities from radiotherapy or brachytherapy. So I've talked about steroid enemas already, sucralfate enemas, excluding secondary malignancies. So the one I haven't talked about is the airborne plasma coagulation. Okay. So these are acute side effects from the bladder. So for radiation cystitis, dysuria frequency urgency, what we need to do, if it is persistent, we need to rule out we need to rule out a urinary tract infection by doing a urine culture. So if the urine culture is done, if the urine culture is done and no organism is isolated, but still the patient has urinary frequency, and the patient also has dysuria, we then label the diagnosis as radiation cystitis. And for radiation cystitis, you may need to prescribe an alpha blocker like tamsulosin that would help to reduce the frequency of urination. So for the pain, the dysuria, you can use some analgesics, but I've read about phenazopyridine, which is a urinary anesthetic that can also be used for those patients with urinary frequency associated with dysuria. So another drug is the flavoxate hydrochloride. It's an antispasmodic or not an anticholinergic. And for anticholinergics, which you want to use to reduce urinary toxicity from treatment, it's important that you're very careful when you're using them in elderly patients. So for acute urinary toxicity, most of the patients will have a resolution of symptoms within 4 to 6 weeks of treatment. So these are some chronic bladder side effects. So for the chronic bladder side effects, it's important to counsel the patient on hydration. Okay, so hydration is important for both acute and chronic side effects like urinary frequency, because the patient will find that he or she would have to be urinating a lot more. Therefore, would also need to drink at least 3 to 4 liters of water to be able to stay hydrated, which is very important. So for patients who is having material blood in the urine, the patients can have bladder irrigation. And the hyperbaric oxygen I talked about is have been done in some studies and was found to be useful. Also, botulinum toxin A was also found to be useful in some studies done abroad. Very rarely, the patient may need to have surgery done for chronic or late bladder toxicities. From the vagina, we can have vaginal mucositis or inflammation. You can have vaginal dryness, vaginal stenosis or shortening, and vaginal irritation or discharge. So it's been flogged a lot. The vaginal stenosis one has been flogged a lot, and it's important that in preventing that, the patient either initiates intercourse early or begins use of vaginal dilators early in treatment. So for chronic side effects from the vagina, you can have dyspareunia or pain during intercourse, which would largely result from loss of elasticity or fibrosis. You can also have ulceration or fistula formation as well. So the vaginal toxicity management would include hygiene measures. These hygiene measures would help ensure that the patient doesn't come down with secondary infections like having a fungal infection, for example, which will cause a lot of discomfort. But where it is we suspect that the patient may have these fungal infections, we can then prescribe antifungal agents to help them. Okay, or if we suspect that the patient is having any other maybe a bacterial infection, we can also prescribe antibiotics. Vaginal dilators is to prevent stenosis as much as possible, and should be instituted early from like 2 weeks post-treatment, and patients should get it done at least 3 times a week. So, or if the patient is able to resume regular intercourse, the patient's partner is available and the patient is willing to have intercourse, regular intercourse should be instituted early post-treatment to prevent vaginal stenosis. Also, topical estrogen creams can be used. This one is to prevent vaginal or to help with vaginal dryness. Remember that these patients may have had external radiotherapy, which would have caused ovarian failure in them. And from ovarian failure, one of the symptoms or side effects of that will be vaginal dryness. So encouraging them to use topical estrogen creams or other hydrating agents or lubricants or moisturizers would also help. With the vaginal irritation, sit baths can also be done to help that. So for pelvic floor symptoms or side effects, you can have pelvic floor weakness or organ prolapse or chronic pelvic pain. So sexual effects would include decreased libido. This would be from ovarian failure. Could also include dyspareunia, which we mentioned earlier, infertility, loss of ovarian function, sexual dysfunction, which results in pain, reduced elasticity, and therefore would lead to dyspareunia. And patients would most often time be less interested in sexual intercourse, which is necessary to prevent vaginal stenosis. So for the sexual dysfunction and fibrosis, the psychosexual impact of sexual dysfunction is very important that you bear this in mind. You shouldn't just be shouldn't just be out to, treat the patients, talk about urinary frequency. Most of the time, that's what we talk about. Talk about diarrhea and other common side effects. This is also important, and many of us, shy away from discussing the psychosocial or psychosexual rather impact of our treatments. It's important that we have this discussion right from the very beginning, right from diagnosis to treatment and even after treatment, because the effects come up after treatment. So we should have started very earlier on so that we can support the patients, get the patient aware of it, and the necessary things to institute would have been done earlier on so that the patient is comfortable as much as possible and is able to calm down. And then pelvic floor physiotherapy can also help, and also neuropathic pain agents like gabapentin and pregabalin can help with the chronic pelvic pain that may result from treatment. Other acute toxicities would include pain, which can be managed with NSAIDs, and if the pain is severe, patients can be given opioids like cocodamol and morphine. So for hematologic side effects, we need to monitor the full blood count of the patient so that if the PCV is low prior to brachytherapy, we get the patient transfused to minimum PCV of 30% or more so that the patients can benefit maximally from the brachytherapy that they're coming for. So we can delay treatment if there's severe cytopenia. So to prevent this or to help with this, we can give the patient white cell supporting injections. And where thrombopath is for low platelets. If the patient has developed low platelets from the external vein prior to coming for brachytherapy, we can prescribe a thrombopath tablets. And where this is beyond the reach of the patient, because it can be it's expensive, we can ask the patient to go for platelet concentrate transfusion. So for serious or late complications, we can have the fistula condition. They're rare, but and they can also be severe. So management will include surgical repair, multidisciplinary care, urinary diversion, colostomy, and infection control also will be very, very important. For psychosocial effects from our treatments would include depression, anxiety, fatigue, poor body image, fear of recurrence, social isolation, work impairments, socioeconomic stressors. So these psychosocial effects, they are very, very important, and it's important that we have this discussed with our patients so that we can help them, walk them through it. So patient education is very important right from the beginning, right from when the diagnosis is made, as we try to do the staging workup to find out what appropriate treatment we institute to the patient. It's important that we counsel them on the possible side effects from the treatment, things that they will need to do as they receive treatment and as the treatment progresses, and even after receiving or completing treatment, what they need to do so that they do not come down, or even if they do come down with these side effects are appropriately managed and patients' quality of life is improved, or the patient's quality of life wasn't decreased so much from what it was prior to commencing treatment. So advanced radiation techniques is also very important. It's using ultrasound guidance, doing high-dose radiation therapy, and all of that, which we have already discussed. So hyaluronic acid gel spacers found was used in prostate brachytherapy to protect the rectum from the prostate as much as possible. So this could also be used and toxicity through the gastrointestinal tract. So for these abuse constraints for the rectum, the bladder, colon, we try not to go exceed 75 Gray to the rectum. For the bladder in our center, we try not to exceed 85 Gray or 90 Gray. And then for the sigmoid colon, try not to exceed 75 Gray total, combining the external beam radiotherapy and the brachytherapy. So acute toxicities are usually reversible. Late toxicities may be permanent. Early detection improves outcomes. Supportive care is essential. Patient education improves that we educate the patients. And sometimes some of the patients when they come, I usually encourage my patients they shouldn't come alone. Because when they come alone and you go, all out to counsel them about the treatment that they're going to need and the possible side effects from their treatment, sometimes they are so emotionally, affected by the cancer diagnosis itself that once they leave your office, they probably forget everything you tell them. So if they came with a relative, sometimes relative would say, oh, doctor said this about this. So that helps. Also putting some of the side effects into print, printing them out on paper or sharing the video with patients or possible side effects and how to manage them. It also helps sometimes when the patient has forgotten, some of the discussions that happened in clinic, they can go back to this print media to check them out and help themselves. Thank you. Any questions at these are my references?
Thank you very much, Dr. Oshikon. Very, 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 very relatable presentation for everyone who is working in radiation oncology. I mean, these are things that you're going to have to face one way or the other. And she has gone into very great detail explaining how we can manage both acute and late radiation side effects. Do we have questions in the house? We want to thank you very much for the presentation, and then we'll take a few questions. Great stuff. So, any other? I'm just going to take 2 questions. So, first hand up, or there's a deflection of blood to the GIT tract.
Thank you, Mark, for your presentation. About as a way of cirrhosis that you encourage the patients to resume sexual intercourse as soon as possible or use a later. So my question is how soon? Yeah. Thank you.
Together. All right, because we know it's just like a refresher.
Thank you. So I did mention 2 weeks post-treatment. All right, so usually we want to complete external beam radiation and brachytherapy within 56 days. So usually patients' external beam radiation therapy will take about 5 to 6 weeks. And thereafter, we have to send the patient for repeat imaging to check what treatment response was like, to know whether there's any residual in the cervix. So going for that investigation can take about 1 week. And then when the patient comes back, we then assess for brachytherapy. Brachytherapy may take another 1 to 2 weeks. So anytime from 2 weeks post brachytherapy, the patient should resume sexual intercourse. Where that is not possible, when the patient is a widow, then you can advise the patient to use vaginal dilators. Okay, so that's so, yeah. Some patients even ask me that can they have intercourse while they are on treatment. Yes, so I tell them you can tolerate it because during treatment there will be a lot of vaginal irritation. So if you can endure it, you like it, or you can endure the irritation. If you can endure the irritation, even while you're on treatment, why not? You can have, especially for patients who come with their husbands or with their spouses. It's important that we encourage this, because it's very, very important. Any other
questions? All right, please put your hands together for the presenter. She did justice. And then thank you so much, madam, for the presentation. Thank you for all the work you did on it. We have had reminders of how to handle complications. In fact, reminders on what complications can arise and then reminders on how to handle them. Thank you very much, Dr. Oshikon. While the presentation was going on, a friend of the house walked in and duty bound to recognize him. Please welcome with me Professor Adeyomoye, who is a consultant radiologist. Yes, you're very welcome, sir. We're very happy to have you. I've been told that he's an Oga and family member. Yes. So we're happy to have you here. Thank you for sparing time to come, sir. You were described as the quintessential gentleman by the bird that was whispering in my ear. So I see it is playing out already. All right, so we'll just have case presentation. Okay, please can you scan the QR code and just please quickly give us a response. I believe it's about a feedback about the conference. So please everyone, we are using Ojaboko for all those. Please bring out your phone and quickly fill out the feedback form. 2 minutes. We just have a case presentation and then the MDT discussion. Everybody loves MDT. I like MDT because it's in the best interest of the patient and it just helps us to do better for our patients. And indeed, we're supposed to have all oncology decisions regarding patients should be made by an MDT. So we just have a practical demonstration of that after the clinical presentation. But before we go ahead with that, we're going to take a quick group photo. And I don't know what magic the photographer is going to do, but we must take it here and in here. I don't know how we'll fit in. Excuse me, sir, photographer. Where is the photographer? How are we going to make it? Yes, but it doesn't look like we have enough number of seats, and I'm worried that the tables will get in your way of the picture. Let's take the MDT first, then we'll take the pictures, right? How many people are there? So case presentation, let me invite who is doing the case presentation? She's here already. Sorry for we have a case presentation. Dr. Lawal is going to do the case presentation ahead of the MDT. She's a senior registrar, which makes her a member of the National or West Africa or both National Postgraduate Medical College, right? Am I right? Okay, thank you. All right, so please put your hand together for Dr. Lawal. Please fill the feedback format, please.
Are we good to go, please? So can you put our presentation?
Yes, you can go ahead, I believe.
Yeah, let's put our presentation.
As everybody, because we're taking it down, if you have not taken the QR code, can you just if you have not scanned it?
You can go. You don't know it yourself. Start with your phone.
Good afternoon. So I'll be presenting Miss AA, a 55-year-old Christian female lecturer being managed for squamous cell carcinoma of the cervix stage 3 C1. She presented to Med-Surg Cancer Center in February 2026 with complaints of vaginal discharge of 17 months duration and bleeding per vaginal of 15 months duration. In August 2024, patients were said to have developed vaginal discharge, which she described as vaginal discharge, which she described as obvious and non-fascinating. She also developed vaginal bleeding at about the same time, and the bleeding was severe transfusion. So she attained menarche at 30 and coited at 16 years of age. She has a history of partners with multiple partners. She has 3 and has perceived history of use of combined contraceptive for about 4 years. She consumes alcohol occasionally and she has family history of cancer. However, in her maternal grandma, however, the type is unknown. Sickle cell disease patients and had a myectomy about 20 years ago. So following development of 2024, however, she didn't have any form of care done until November 2025 when she presented to another peripheral hospital where she had endometrial and cervical biopsy. Finding was that of endometrial carcinoma in the cervical biopsy and the squamous cell carcinoma in the endometrial biopsy. In December 2025, she had an pelvic ultrasound done, which showed bulky uterus with heterogeneous endometrial epitexture. We measured 9 cm by 5.7 cm in size. There was a fibroid seen in the endometrial wall, and the endometrium was seen with generative changes. There were also multiple nodes seen in the left iliac region. In December 2025, she had a total abdominal hysterectomy and bilateral salpingo-oophorectomy done at the same peripheral hospital. In the results for surgery in 2026, it showed infiltrating polydifferentiated papillary serous carcinoma of the endometrium and positive malignant cells similar to that of the endometrium. She was referred for chemoradiation in February 2026. Our presentation to the cancer center, she had she was reviewed and examinations were done with no abnormal findings. Her echo was 0. She had abdominal pelvic CT scan done. MRI couldn't be done because patient had dental implants that precludes MRI. So she had a CT done, and the CT showed a cervical stump measuring 2.9 cm, 1.1 cm in diameter with no evidence of disease recurrence. She had evidence of left internal and external iliac nodes with multiple benign hepatic cysts. Her chest CT scan showed no evidence of disease metastasis. She had immunohistochemistry done on account of the confusing histology she had, both from the 2 histologies done. The P16 showed the mosaic pattern. Her retroviral screening was negative. So she completed chemoradiation in April 2026 and is currently being worked up for brachytherapy. The patient is yet to come back with her repeat imaging so that she can have her brachytherapy session. Thank you very much.
Okay, thank you very much. So we're basically going to discuss this case management as our NGT. And so joining me on this panel is We have 4, 5 seasoned people. Okay, sorry, I didn't tell one of them that way. Okay, so joining me will be consultants with. I will give a radiation oncologist. A consultant radiologist who has been part of our journey since inception. Professor Adeyomoye is a member of the family, actually qualifies to be a radiation oncologist. And just small training like this, we just change his way. So he's a radiologist, and so he's going to be one of the panelists. Please come up, sir. We have another family, a gynecologist who is a go-to person. A person of, he's a gynae oncologist, not just a gynecologist that specialized in oncology. And that's the person of Dr. Ephraim Owazuwike. And he's been a friend from 1804, making sense since UI. So, I also have a friend, a sister, somebody they said our placenta has been joined together, and she's a radiation oncologist, and we're in the family together, the person of Dr. Halabi Adewumi. Joining us virtually against all odds, and she has squeezed time to join us in person, our pathologist, in person of Dr. Hakinjo. She's joining us virtually. She's a pathologist in Zeus. So I hope you are seeing her. Can we please show our picture so that we know? Okay, and last but not the least, because we want to know what it feels like outside the shores of Nigeria. So I'm going to be inviting Professor Ravi to kindly join this panel. Sorry. But let's see things will have been different from your head. Thank you. Okay, so basically we're going to be I need a microphone for them. We're going to be discussing this patient management. So essentially, these cases come such that you don't even know whether it's an endometrial CA or cervical CA. A lot has happened. So I think in some instances, you even have them taking, like in this instance, biopsy taking from the cervix and endometrium. So you don't know whether it's cervix, it's endometrium. And ideally, your total dose that you are aiming, where you are aiming to treat, differs. So you really need to know which one you are treating, your approach, it goes a long way. So I'm going to start from, okay, Dr. Alabi, as an oncologist, you see this, I think let's start from Dr. Owazuwike. Yeah, it starts from them. It starts from the gynecologist. They do the surgery, take the biopsy, and gives us something that is really confusing. We don't even know where we stand. So how do we handle cases like this? Thank you.
To start with, she had biopsy, cervix, endometrial, and then subsequently had surgery. If I'm going to send for immunohistochemistry to start with, I prefer to use
What you have done better as a gynecologist to avoid this confusion.
Yes, now,
I know what I'm treating.
yes, so where to start from is from your evaluation. So that is where Prof comes in. All right, your initial evaluation, imaging is very, very important. And from the imaging, you have something at the back of your mind. There's a case that I'm managing now with Dr. Habibu, a patient with cervical mass extending to lower uterine segment. Somehow this patient has been managed for cervical CA for so long, but she wasn't getting better. And then the patient came to me, and when I looked at the patient, I felt we don't know managing there. Of course, we had to retrieve the tissue block, send it abroad. P16 was positive, but she has mutated P53. Now, P16 being positive will make you think it's cervical, but in CA cervix, P53 is not mutated. All right, you always have white out P53. So that gave the diagnosis away as endometrial. So she's been managed one way from the start. So this patient will probably have benefited from surgery, then, right, so they doing chemo radiation. So everything comes from your evaluation initially. But the problem most times, especially with us clinicians, is that we don't take time to evaluate our patient. We need to up our clinical acumen also. Your pelvic examination, your clinical acumen has to be up there. You have to be a good diagnostician. And then you will have less of this problem. Yeah.
Thank you. So goes back to a clinical examination, your diagnostic acumen, your physical examination and imaging. So at least and other things like the epidemiology, you know the age, you know some other things you can be able to say. But we really need more from the gynecologists to avoid this confusion. Thank you. So I'm going to go to Professor Adeyomoye. From your, as a radiologist, it's not twice that we have called you that, okay, I don't know. How do I try to place it, whatever it is which? So from the radiologist point of view, either pre or post-op, because most of the ones that give us the most issue are post-op, and we don't know which is which. What do we expect from you, sir?
Thank you. Well, it's a function of the stage this patient is presenting. In most patients who will present early, imaging is not a good diagnosis. People in their 50s, late 50s and 60s tell you, I've stopped meditating for about 10 years and I'm bleeding. And at times you tell them, okay, do imaging. Everything looks normal. Just tell them, go and do biopsy. It comes out like something very different. But usually, in those who have bulky tumors, then it's easier for imaging. So there are some things we look at for the epicenter of the mass. We know that it has to where the bulk of the mass is. Most unlikely that a tumor will be a cervical tumor and the bulk will be the endometrium. Or a tumor will be an endometrial tumor and the bulk will be the cervix. So that will help us. The other thing that can also help is the pattern in which they spread for those who have late-stage disease. Most cervical tumors will go to nodes, the pelvic nodes, and all that. A lot of the endometrial tumors may not go to nodes. And so you say, oh, this thing is confined to the uterus. Fast forward 6 months down the line, the patient comes back, we are seeing masses in the abdomen. And prior to that, everything looks clean. Then the one that is most confusing is when you have to check this on CT. On MRI, it's straightforward. Because MRI has very good soft tissue resolution, you can determine place. On CT, it's very, very blurry. Guide imaging on CT is very, very blurry. In fact, CT is inferior to ultrasound. Aspect of the body. Because CT is not meant to be telling you, okay, one ovary has been removed, this is uterus, because the resolution is poor. Quite a number of times patients come with recurrent disease, and you see a tumor that looks like the uterus, and you say uterus is normal size. They will say, can't you see that the uterus? They say, how do I know? Because CT will not show you the endometrium. But on MRI, you know, I'm not seeing endometrium, this is not uterus. So those are things that we will have to use. So for a lot of gynae oncology cases, MRI is very good. It gives you very good resolution, the stage is better than CT.
Thank you. Thank you very much, sir. So you mentioned epicenter. Is it epicenter? Okay, no, not epicenter. And then it's so interesting to know that maybe what we're running after is actually, we should not be running after what we're running after. If CT is inferior to ultrasound, so like Dr. Eko was saying earlier, we need to up our skills in ultrasound, really. So, and then some patients are wondering, why do you prefer some centers? So it was because due to number of times that we have interacted with these people, they know what you are looking for and they will help you to look for what you are looking for. So maybe for some patients that are so indigent, instead of insisting on CT, maybe not in a setting, it might be good if you have a good sonographer or a radiologist that can give you a good report, you might need to be exploring that. Thank you very much, sir. So Dr. Akinjo, please can you give us from the pathologist's point of view, how do we solve this dilemma of knowing whether it's endometrial CA or cervical cancer? Thank you.
Okay, good afternoon, everyone. Thank you. So I think because I noticed in the presentation, the squamous cell carcinoma was said to be in the endometrial biopsy, and the endometrial carcinoma was said to be in the cervical biopsy. That's the chances of having, so it is usually meant to be the reverse. You tend to have endometrioid more common in the endometrial, and squamous more common in the cervix. So in this case, if there's a confusion about what is in the histology, I think the first thing is to get a second opinion, to get the tissue blocks and get another pathologist to review and look at it. So both for the biopsies and then for the hysterectomy sample. So I think that would be the first step to take before we start talking about immunohistochemistry, because the only immunohistochemistry I saw that was presented was P16. P16, you would need to combine other markers to be able to, but the first thing is to first get what is on the H&E before you even move on to that. Then you now decide which markers you're going to use, because in this case, we are not sure what is whether it's from the endometrium or the cervix. So that would have been the first step. First step is to get a second opinion on the H&E, and then decide on the markers to help to, if the H&E cannot help to differentiate, then to now decide on other markers. Apart from P16, the other markers there, you can determine whether it's on the endometrium if you do markers like ER, PR, especially for endometrioid. PAX8 can also help. So I think the first step is to get the basic histology picture and then decide if there is a need to do more markers. Because I feel that doing just P16 is not very useful in this case.
Thank you. So that's one of the things we are trying to arrive at as a center. That when a patient is coming, we've been asking for histology, then I want to move to asking for the tissue block because of this second opinion. And then before now, we have engaged Professor Banjo, and then I was told that cost of repeat analysis for this histology is less than 20,000. Maybe she mentioned 15,000 or less. So telling people from other centers, so when you see us or you are sending your patients, you can also as well do us good by sending the tissue block, because things do happen. And some of these patients have traveled from far. So asking them to come, logistics to consider that. Then as per the immunohistochemistry requested for, patients are paying out of pocket. You are looking for what will come out fast, you are looking for what is affordable. So Dr. Akinjo, you still help us to list all the markers that we could actually use to differentiate and maybe a cost, because we still need to come down to what is affordable, because you are trying to manage funds too, because all these ones you are just trying to make a diagnosis, you have not even got into treatment, and you have spent millions. So definitely you lose some patient out. So if you don't mind, which other markers can we look at for? But then the first point is well taken, and then we are getting there as a center. Thank you.
Okay, so like I think Dr. Alabi would remember that there was a conversation about immunohistochemical markers in the neuro MDT meeting we had. So usually you start from a baseline, especially if you are not sure of what you are looking at. But usually that baseline may expand because the baseline has not really helped you to make a definitive diagnosis. But for example, now, if we wanted to differentiate between a tumor coming from the endometrium and a tumor coming from the cervix, you would start with at least 5 or 6 markers, which would include ER and PR, which tend to be positive in endometrial tumors. And you would also do AX8. You would also do P53 and P16. P16 tends to be positive in cervical tumors, but it can, which are HPV related, but it can be positive in serous endometrial carcinoma. So it's also, you also have to know how to interpret your findings and to be able to say, okay, this points to this. And then Vimentin also helps to distinguish whether a tumor is coming from the endometrium, which will be positive for Vimentin, or is coming from the cervix, which will be negative for Vimentin. So usually we tend to start with a baseline of 5 to 6 markers, but you might need to expand the number of markers. That's why it's difficult sometimes to tell patients this is the amount you pay, because each marker comes at a cost. So sometimes it increases as you are going through, but usually we have to go through at least the ones that you used to rule out and rule in, and you need at least 5 or 6 basic ones.
Thank you very much. That's quite helpful. Thank you. So please still stay online. I have one more question for you, but not now. So Dr. Alabi, as an oncologist, when a patient comes like this and you don't know which is which, what's your approach?
Okay, so thank you for the question and for the summit. I think as an oncologist, I want to put all the information together, starting from the clinical history of the patient. So this patient is para 0 plus 3. So I don't know what the plus 3 definition is, whether it was qualified well. So whether to call this patient low parity or no parity at all. So we may have to look at that. Then there's a history of multiple sexual partners in her partner. Okay, so we have to look at that. So we may want to start from the history to differentiate what's the risk factor. Are we looking at endometrial? Are we looking at cervical? We're talking about personalized medicine now. So it's good to manage what we think best this patient has. And just like Prof has also said, imaging actually showed more of a uterine mass from the image, if I remember correctly, what was presented. And so we have to tie all these things together. And then now we have come down to say surgery result has come out and we're seeing poorly differentiated endometrioid. So for me, it's tending towards endometrioid. It may end up being cervical. And so when I now want to come down to my treatment, I think what I would prefer to do is look for the treatment that can suit both patient cases, making sure that this patient is not undertreated and this patient doesn't come back in a few years down the line with metastasis. So many things are in favor of endometrioid, as we're also having a conflict in whether it is cervical or not. So the patient will have chemo radiation, the patient will have external pain and have brachy. So but I think this patient will also benefit from a few cycles of chemotherapy, since we are not sure, except we're ready to do all those markers that Dr. Akijo has spoken about, or else we'll wait for the metastasis to come up, which may not be ideal, or the patient may never have metastasis anyway. But for the fact that we're having something conflicting, I think it's advisable we give a few cycles of chemotherapy to this patient. So I don't know, others may have a different opinion.
Thank you. So Professor Ravi, what would have been your approach if you are managing these patients?
This
is a very interesting case. My first thought when you said the cervical rupture was adeno and endometrial rupture was that were the sites labeled properly. So that is a common mistake that can happen anywhere, and we see that kind of mislabeling as well. So at our center, every patient that comes to the hospital will be discussed in a joint clinic where we have a gynecological oncologist and med-onc and pathologist. So oftentimes when there is a discrepancy, we look at the imaging during the joint clinic because we have an electronic medical record system where we can see all the images including MRI. And of course, like the video just mentioned, MRA will give you where the epicenter of the disease is. But I think the most important learning point here is we should not be looking at narrow things like only radiology or only pathology or only from oncology perspective. We should get all the information together before making the treatment plan. I think that should be the true essence of a multidisciplinary discussion. We have had patients where biopsy was squamous cell carcinoma, but on imaging we saw that there is uterine extension almost in the fundus. Uterine extension in cervical cancer is known, even in squamous cell carcinoma, but looking at the epicenter, looking at the way the disease is growing till the fundus, we did went ahead with surgery as the first treatment of choice for those kind of patients, and the final stop turned out to be a hybrid serous carcinoma or sometimes carcinosarcoma. So we do see some kind of things like this. Secondly, like the pathologist mentioned, immunohistochemistry is very important. And it is very important to understand that immunohistochemistry is an additional tool to histopathology. So if I'm not mistaken for this case, the final histopath report was papillary serous carcinoma, right? So papillary serous carcinoma is primarily diagnosed based on histology, and of course there are certain HC markers like WT1. Of course, WT1 is primarily for ovarian hybrid serous carcinomas. It may not always be positive in endometrial hybrid serous. And if you look at hybrid serous as a histology, the incidence of hybrid serous in endometrium is relatively well known compared to the incidence of hybrid serous as a histology in cervix. So if there is a hybrid serous carcinoma with epicenter the endometrium and involvement of the cervix, we would treat the patient as endometrial or uterine hybrid serous carcinoma, where the patient would undergo surgery followed by chemoradiation or protective protocol, because hybrid serous carcinoma by itself will make it a high risk endometrial cancer. The other thing is subtotal hysterectomy is not the standard of care for any kind of oncological surgery. So if sometimes when we see this kind of cases and our surgeon opens and sees that cervix is grossly involved and we cannot remove it completely, they abandon the surgery and then send back for chemoradiation, because remove the uterus, I will not be able to put in the tandem. I will not be able to deliver proper dose. So that is one thing that we have to talk to the surgeons also, that even if it is squamous carcinoma of cervix, if they look early stage, if they want to operate, they open up. First thing they do is lymphadenectomy to find out if there are any nodes. If there are no lymph nodes, if they think they cannot remove the entire thing in toto, never go for subtotal hysterectomy. Leave the uterus intact so that I can do good brachytherapy. If you remove the uterus, then I will not be able to put in a tandem. The entire treatment will go for a loss. So if a patient comes like this, endometrial hybrid serous primary without parametric involvement, underwent a subtotal hysterectomy, then our first treatment of option would be to go for a completion surgery, because hybrid serous carcinomas do not respond well to radiation. So even if it is a cervical primary, if the histology is hybrid serous carcinoma, if there is no parameter extension, we go ahead with surgery followed by adjuvant chemoradiation, because we know for sure that squamous cell carcinomas respond best to chemoradiation. Adenocarcinomas also respond to chemoradiation, but the response requires more dose, approximately 10 more than the squamous cell carcinoma, to achieve the same local controls. And hybrid serous carcinomas do not do well with chemoradiation. So that would be our recommendation for this patient.
Thank you very much. Thank you very much. So a whole lot has been said here. So one of it is to also reinforce the importance of NDT. Unfortunately, in our setting, we see loads and loads of patients, and we want to go through NDT for all of them. It's almost looking impossible, but then we cannot be overemphasized. We need it, and we just have to find a way around it, no matter how you work, for the benefits of this patient. That's when we can give the best. And then thanks to COVID, and then we're now very virtual. So we can actually organize it at any time of the day, whatever is convenient, and let it work. So we're going to improve more on that. So for final word from all the panelists, basically to you as a radiologist, I'm going to start from Prof. What does precision and personalized medicine implies in radiology field, especially when we are thinking of cervical cancer or GYN cancers generally? Thank you.
Well, most of the radiology have said, we cannot overemphasize the importance of community. And it's also good that, because if you have an entity team and everybody's carried along, then everybody will be at the same page. And it's also good for patients to have imaging by that entity rather than you have an entity, patients go to Center A, has imaging, Center B has imaging tomorrow, Center C has anti-imaging. Everything becomes disjointed, there is no comparison, they don't have an idea what was done, what is being done, and it makes it pretty difficult. And of course, the other thing is choosing the most appropriate imaging for patients, especially in an environment where cost is an issue. So it's no use saying that this patient cannot afford MRI, you go for CT, and CT will not adequately assess what you want. And so you treat based on that, and you now say, oh, this thing is not responding. So it's been a case of being penny-wise and foolish. And of course, there are other imaging that can be used to assess specific things. With radiology, once you can tell your radiologist what you want to assess, they can tell you, okay, if it's the liver you're interested in, we can say, let's use ultrasound. Ultrasound will do well to assess the liver. Rather than say, oh, everything wants over MRI. So, I think that's about it.
Thank you very much. Thank you, sir. Okay, so to Dr. Wazuriki.
Self personalized medicine, right? It's extremely important, and that's where the whole world is going right now. There's nothing like one straight jacket fits all anymore. I tell my residents, endometrial cancer is not endometrial cancer for everybody. So you can't treat everybody the same way. Your approach has to be individualized. And that is always the key for me. Your approach has to be individualized. You can't just make up and say because the drug is in your hand, then you can just throw it and then no. Your approach has to be individualized. And as a people, I think we should also begin to challenge the system as well. I find out that one major problem that we have in oncology care, in oncology practice, is pathology. Not because we don't have excellent pathologists. We have fantastic pathologists, but we don't have the resources, we don't have the infrastructure. All right, and again, the clinician on the other side, you get a result from a pathologist. It says adenocarcinoma, and you just continue running with adenocarcinoma. You know, adenocarcinoma is not information in modern day oncology practice. You can't just say adenocarcinoma and then you're running with it. It's not enough information for you to be able to deliver personalized medicine. You need to ask more questions. You need to, probe further. All right, respectfully, though, you have to probe further so that we can be able to deliver what is appropriate for each individual. All right, everybody cannot get the same thing. You understand? And again, to us, the surgeons on this other side again, we need to also up our game as well. All right, everybody cannot get radiation. So if we stage our patient very well, right? Like this patient was not properly staged, was not staged at all. The patient was not staged, so we don't even know the stage of the disease. All we knew was that uterus was taken out, and if you don't stage your patient, you're going to overtreat, you are likely to undertreat, and not the rest of them. So these are things that we need to sort out in our environment before we can say yes, we are getting.
Thank you very much. So, Dr. Akinjo, I would like to ask you as a pathologist, what does personalized medicine mean to you and how do we approach it from your angle? Thank you.
Okay, thank you very much. So, I think the first thing, because when we think about personalized medicine, start thinking of all the technological things. So I think the first thing is to, which I think everybody has agreed on, is to make sure that the MDT is a central part of the management of patients, because doctor has been having regular gynecology. We, the pathologists on our part, we know what ones they and we know what is required in their reports. But of course, we are limited, like you said. We most times we can't go beyond H&E. But even if we can't go beyond H&E, we can go that extra mile to determine prognostic factors that we can see on H&E, and then we can communicate that to the gynecologist. But as we know, everything is moving towards more and more advanced and complicated. So that's immunohistochemistry, molecular testing, and we have limited resources. We have limited access to those things. They are expensive when they are available. So I think it's to also push for more of subsidized access to immunohistochemistry and molecular testing. And we have something like that for breast now that has come through the Ministry of Health and Roche. So I think if we push more for that, then more patients can access, because whether we like it or not, we are moving more and more towards molecular determination of behavior of tumors, and we can't rely just on the basic H&E we have. That will give you a baseline, but you need to know how is this tumor going to behave, what are the prognostic markers, what are the things that you need to do for this specific patient. So we really need to start looking for ways to make these things more accessible, because they are too expensive for most people. Thank you.
Thank you very much. So let me use this opportunity to officially and formally inform you that we're drafting you into our MedServe MDT. We listed out your name. We're going to reach out to you. So we'll still reach out to you, but at least take this as our first invite, both for GYN and breast. Thank you very much. So we can release you now. Thank you very much. Okay, so we continue. So to Dr. Alabi, how do you approach personalized medicine for your patients?
So I think personalized medicine is all what we have been discussing all day. And so we're just saying we want to tailor the patient's treatment to the type of cancer the patient has. Adenocarcinoma is also different in so many ways. Squamous cell different in so many ways. So, but the bottom line of what we have also said today is that we are faced with a lot of challenges, especially in this era or area we have found ourselves. And so it becomes challenging to manage the patient, not because we don't know the stuff. We know the stuff, we know, but we don't have it. And then not only that, our patients, you can imagine having to tell that patient to go and do all these 5 panels that she has mentioned. I'm sure they won't cost anything less than 2 million naira. So where will the patient get it? So how will I be informed to know what or how to treat the patient? So personalized medicine, we are getting there. We'll keep pushing. We'll not give up. We'll keep pushing and see, prove ourselves and how we can help our patients better. And at the same time, what we have, we will use that to stratify the patient to what will benefit the patient the most. So I think for me, personalized medicine is tailoring the patient to what the patient needs and also considering what is available within my locality. So thank you.
Thank you. So finally to Mr. Ravi, how do you practice personalized medicine in India?
I think I have a slightly different perspective on this. Uh, if you have 100 patients with cervical cancer, whatever you may say about personalized medicine, the treatment for 95% of them is going to be the same. The problem is we don't know which are the 5 patients within this group of 100. So identifying those 5 is, in my opinion, the scope of having a personalized medicine kind of a discussion. And it can never be done by a single person. It should be a team, and I think that should be the important message here, that any kind of medicine, be it endometrial, see, if you talk from a diagnostics perspective, it can be at histopathological level, it can be at molecular level, it can be at IHC level, it can be at genetic level. But still, it should always be discussed in a team, so that we should not think that we are the most intelligent person in the room. So we should always get input from different departments and then make a plan and then treat. And that, I think, is a crux for personalized medicine.
Yeah, thank you very much. So a lot has been said, and most of them we know. Some were building on it, but whether we like it or not, treating cancer by a single person is near to murder. Is that murder? So against all odds, we just have to push for this MDT, because I imagine these patients, even if we have discussed this in MDT, our approach might have been slightly different. But when you are thinking of how to run after these other people, everybody is busy, especially in Nigeria, everybody is overwhelmed. So how to run after these people to discuss this case? And time is going. Patient might have even come from outside Lagos, wants to be treated now, and you understand a whole lot. But against all these excuses, you just have to find a way around it. So as much as possible, we're going to start NLCC Gynae NGT, NLCC Breast NGT going forward. You see whatever we can actually discuss cases, even if there's no time range, we start on Saturday after our OM base. Okay, to those that have left, I want to say thank you for this session. It's been very, very helpful, and we're going to get better. Thank you very much. Okay, so before the closing remark, we have want to present some gifts to our sorry, we're going to take a good photograph. Don't go. If you go, you are disqualified for next year. So sorry, please just wait there with us. In the next less than 10 minutes thereabouts, we have a day. So at our distinguished guest speakers from India, we have this plaque to present, and yeah, so I'll be calling on our professor, first female oncologist in Nigeria, first female radiation and oncologist in Nigeria, to present this award. Okay.
Good evening, everyone, and thank you for those who have stayed till now. I know it's a lot of sacrifice, and with this subtle blackmail, threat and blackmail so, this is to Dr. Please, can you pronounce? I want the right pronunciation. The right pronunciation. Yes. Raghavendra Hazari. Okay. Because I'm saying J. So, This plaque is from MedServ Cancer Center, saying thank you to you in appreciation of your contribution as a speaker at the 4th Annual Brachytherapy Summit with the theme Precision and Personalization in Brachytherapy, Applications and Future Direction. We appreciate you and thank you so much. Looking forward to seeing you next year. So, and then this is for Prof. Ravi Teja. Miriam. Okay. I'm learning. So, okay, Ravi. This is from MedServ Cancer Center. You know, in appreciation of your contribution as a speaker at the 4th Annual Brachytherapy Summit with the theme Precision and Personalization in Brachytherapy, Applications and the Future Direction. I want to say thank you. We appreciate you. Your lecture was impactful, and we hope we'll be here next year. Okay. Thank you. It's over.
Thank you very much. So I don't have any closing remark, but I will call my boss, Dr. Hepo, if she has, because I put so many requests forward. So let me start closing now ahead of next year. And give her the honor of doing the stand up and to the person that is controlling us.
Good morning, madam. Good morning, madam. Our driving force.
Yes,
How do you tell it? You have to respect the content.
It's like to enter my pocket. Okay, well, thank you so much, everyone. Thank you to our speakers from India for joining us. Thank you all for staying this long. I know it's a lot of work, a lot of intense learning and knowledge, that has come forward in this last 2 days. But it's a pleasure to have hosted you all. We hope that we can have a bigger budget and have a bigger house, bring more people down, so that we can indeed learn and improve the practice. I always say the benefits of meetings like this is not to judge all, but to see the things we can do to improve our practice and really make things better for our patients. We already know that cancer burden is highest here. When we had the discussion on HPV vaccination, is highest in Nigeria. We want to change the narrative. That's really what MedServ Youth Cancer Center is about. And cancer, we all know cancer care is not one person. So it's not just us, the 10 oncologists or 16 radiotherapists in MedServ Youth. It's all of us sitting in the room, going back to our different centers, finding how we can collaborate. Even in the research, the stuff that we say, the papers, work coming out of MedServ Youth Cancer Center. We want to collaborate, let there be cross-institutional collaboration so that we can really, really change things for this country. So thank you so much. Godspeed as you go back to your centers, and we hope to see you next year.
So we have a group photograph just outside the auditorium. Thank you so much. Let's complete.
Thank you. Yes. I'll share with you the picture. I did not take it off the phone, but I will get.
That's okay. We'll get it later.
Yes, I will see it.
Sure. Yeah. Thank you.
This is the plan to go to.
I think it's already late. We'll see.
Open? Is it open or no? Is the light which is there? I feel it's dark already, so
No use?
it's like about 1 hour to get there.
It's 1 hour.
1 hour to get there. By then, the sun is setting. So maybe if you're here around tomorrow,
Tomorrow at 2 o'clock we are going. Morning. So no use now?
Wow, that's very
I want to see anything else.
like what exactly do you want to see?
Anything.
Just 2 days before.
Well, I think since you are lodged around the cage, I believe, if you are lodged around there, you can just explore.
Please join us for the group photo. Okay.
Keja Mall or something like that. Cinema.
Recording stop.
Yes, sir.
Don't stop that.
No,
That's
the last.
Josh, all your things are in chat, are you? Yes, ma. Josh, please, Mike.
Yeah, David, please, Shay, there's a mic, Shay, that wireless mic. It's around. Very much around. Well done, Chief.
Okay,